This meeting is being recorded.
Welcome back, everybody. We're moving on with the afternoon's programme. And thank you so much to everyone who's logged in. It's been really, really high quality in terms of all of our lectures this morning. And it's really starting to piece together to answer some of these questions. So we've heard about physiological repair and a lot of the basic physiology of the right ventricle and of CCTGA. And we're moving on to talk about anatomical repair now. And this is the second of our named lectures for the course today. This is the Bill Williams lecture. William G. Williams was the chief of surgery here until 2006, and really a much loved and respected character around the world, and really introduced to kind of the philosophy really of mentorship and bringing on the next generation of surgeons. And Bill is still very active, and we see him all the time here, and he still helps run the database, and is here joining us today with his family. So thank you so much, Bill. The lecture is named for him after the Chung family. That's a picture of Bill with William Chung. Bill operated on William's son now more than 20 years ago. And really as a consequence, I think, of what the Chung family found here at Sick Kids, they've been enormously supportive donors, not only to support this lecture every year, but also with the Bill Williams Directorate at the chair in cardiac data analysis. So we're enormously grateful to the Chung family, who again, I think William and his wife Carol and his family have joined us today very kindly. So thank you so much. And this is the Bill Williams lecture. So I'm going to introduce Ram Amani, who's very kindly agreed to talk with us today. Ram is a surgeon at Boston Children's Hospital, associate professor at Harvard, and really one of the driving forces in congenital heart surgery across the world today. He's been very eminent in terms of looking at ventricular rehabilitation, but also very much in the outcomes of anatomic repair, or the double switch for congenitally corrected transposition, where they've recently published several papers on their experience, which have been extremely enlightening on where we need to go with anatomic repair. So Ram, thank you very much for agreeing to talk today, and I'll pass it over to you.
Thank you very much, David. And it is indeed a great honor. I'm extremely humbled and honored at the same time to be able to present today. And I'm sure my talk will not do justice to the legacy that Dr. Williams has left for us. I never had a chance to meet him directly in person, so this is a great honor to be speaking here and visiting Toronto virtually. I'd like to talk a little bit about some of the surgical considerations and thought processes for anatomic repair for CCTGA. And it's been quite a wonderful symposium so far, and really highlights the complexity surrounding the decision-making and treatment of patients with CCTGA. And I want to distribute my talk a little bit into components. First, addressing my perspective on what is the right strategy and how do we think about comparing the various options. To think about what the age window is for retraining and anatomic repairs. I think that's certainly been highlighted earlier today as an important factor. And then talk about some of the technical considerations. I will say that although it'll be evident that I prefer the anatomic repair, it's by no means established as the clear right choice. And some of this has to do with really the variability in outcomes after anatomic repair. And this forest plot here really highlights that point. That is, there may be differences in patient populations, institutional experience that factor into how these decisions are made. So knowing fully well the heterogeneity in this population, I really prefer to think about the populations in terms of their anatomic subtypes. So let's start off by talking about corrective transposition with intact ventricular septum, because I do believe that population behaves differently than the patients with VSD and PS, and so on and so forth. So trying to tease out the best management by necessity asks us to create categories and buckets of patient populations that we can analyze separately. So here we analyzed our experience with 128 patients with corrective transposition and intact ventricular septum. And you can see in this diagram sort of the various management strategies that many of you will be familiar with. I think no surprise to many of you that if we look at the population of patients with corrective transposition and intact ventricular septum, the management of physiologic or anatomic, those subsets differ in terms of the age at presentation and the age at which the anatomic repair is taken up. So here you can see in the orange, patients who are undergoing a double switch operation or anatomic repair tend to be on the younger side compared to those that we're managing with a physiologic circulation. Again, no surprise there. Now, we wanted to look at how do you compare apples to oranges? And we wanted to ask ourselves, mortality is clearly a good endpoint. Transplantation is a good endpoint. But then comparing the right ventricle to left ventricle in terms of systemic ventricular dysfunction and AV valve regurgitation. These are sort of our composite endpoints that we looked at. And we tried to compare an unadjusted all-comers with intact ventricular septum, what happens to them over time. And we take at time 0, really birth. So we take all comers age at analysis, and we look at our database and say, well, what happened? Some of them presented later, some of them presented early. We tried to account for some of that. And in this analysis, there seemed to be a signal that is, if we look at the endpoint metric, maybe there is a difference between anatomic and physiologic repair. Clearly very different patient populations. And after adjusting for age at presentation, the presence of tricuspid regurgitation on the first echocardiogram, and so on and so forth, trying to correct for those various differences. Again, we did find a signal that is anatomic repair having a favorable outcome compared to the physiologic patients when we looked at the freedom from those endpoints that I described earlier. Now, again, we tried to further correct for the differences in age by restricting our analysis to patients that are less than 5 years of age. And again, we saw some signal in that our anatomic repair patients seem to have a better freedom from intervention compared to those who did not. Now, this is looking at a cohort of patients that is somewhat historical, and so it's hard to tease out the era effect from many of this. So I don't mean to sort of tell you that this is clearly flaw-free data. There are clearly biases and confounding factors that we just cannot tease out from this. Well, let's move on temporarily then to talk about corrective transposition with ventricular septal defect. Again, a very complex treatment algorithm that I won't tease out in this diagram. What I do want to share is that if we look at the subgroups, the patients who underwent an anatomic repair compared to those that underwent a physiologic repair, and we look at different snapshots, what happens to the ventricular function over time, it probably does not come as a surprise that in the anatomic repair subgroup, there are some patients who do develop some degree of morphologic left ventricular dysfunction over time, And here you can sort of see about about 7% of patients, and we'll get into that in a minute. If we look at the patients who underwent a physiologic repair, however, there are probably a larger portion of patients who have moderate or greater ventricular dysfunction at most recent follow-up. And again, this is not correcting for time. It's not a Kaplan-Meier time-based curve, but if we then try to put into a composite endpoint of ventricular dysfunction, tricuspid or systemic AV valve regurgitation, and again, comparing systemic ventricular and systemic AV valve dysfunction within the two groups, again, looking at this over time, you can see that it really does take a while for the anatomic and physiologic repair subgroups to start to separate out, but there did appear to be a separation. In here, this is the patients who underwent single ventricle management with the Fontan circulation. Now, I think there are subgroups even within the CCTGA VSD, and the presence of pulmonary stenosis is clearly another modifier. And as we've heard about earlier, the presence of associated lesions does impact the outcomes with these patient populations. And so it starts to become murky once you start to tease out really subgroups of patients as to whether or not one strategy is better than the other. So how do we put this all together? Clearly, there is a reasonable approach in which one can consider a patient with morphologic right ventricular dysfunction as better served with an anatomic repair, whereas those who have some degree of morphologic right ventricular dysfunction or systemic tricuspid regurgitation, that they may benefit from an anatomic or an observation approach. Of course, this is the Boston approach, which you know, I'm being somewhat facetious, but in reality, this is kind of the approach that we have taken institutionally for better or for worse. I want to shift for a minute to talk about retraining of the ventricle and the timing of pulmonary artery band, particularly for patients who have intact ventricular septum. This is an older study that we performed to look at the impact of age upon a composite endpoint of aortic insufficiency and systemic LV dysfunction. And clear, what we saw pretty pronounced was that if you waited beyond 2 years to place your pulmonary artery band, that you did have a higher incidence of adverse outcomes from the double switch operation. And so this lends credence to the thought that perhaps an earlier pulmonary artery band is a better approach if you're going to pursue an eventual anatomic repair. Enhanced retraining with creation of an atrial septal defect is something that we're performing more consistently now in Boston, and has been shown in a handful of patients now to have more consistent increase in left ventricular mass and other measures of preparedness. But this really brings us to the question of how do we assess preparedness in a patient that we want to get to an anatomic repair after having performed a pulmonary artery band. Certainly, we use cardiac MRI. We use cardiac catheterization to help us obtain some of these numbers: LV mass and wall thickness, the peak systolic pressure, the pulmonary artery gradient, the ejection fraction of the left ventricle, and the end-diastolic pressure all go into the decision making. But there are no clear thresholds. I will say, and I really credit a lot of this to Dr. Reddington, who spoke earlier about thinking about more sensitive measures of function. And Erwin earlier had really emphasized the importance of obtaining pressure volume loops. And I think we've sort of drunk the Kool-Aid on this one. We are now performing pressure volume loops more routinely. So this is an example of a patient who has had a pulmonary artery band in the yellow prior to a pulmonary artery band. The blue circle is after a pulmonary artery band, and the red loop is now a year after pulmonary artery band training, and we see that the left ventricular loop looks more normal. And so we're looking for not just absolute measures, but also what happens to these metrics over time. And you know, here in this particular situation, clearly there are a number of things that changed. The DPDT, the diastolic function, many of these are now can be teased out with much more detail with conductance catheter. Again, we don't have any data yet to show how best to use these data, other than to say there should be thought that goes into determining when a patient has indeed been prepared for their subsequent anatomic repair. I want to talk a little bit about the technique and some of the technical considerations for anatomic repair. I like to do the mustard reconstruction, which allows, I think, for a less of concern for pulmonary venous obstruction. So I tend to use actually a Gore-Tex tube graft that's filleted open, and use two limbs, so create a superior vena cava limb and an inferior vena cava limb. I feel like the geometry of an atrial switch is complicated, and trying to get those baffles right just with a single patch can be a little bit difficult. So I've chosen to do it in two separate limbs, and this has really reduced the incidence of kinking or stenosis of the systemic venous baffles in my experience. The other important consideration is what you do with the neo-aortic root. We tend to remove as much of the thinned out pulmonary artery neo-aortic tissue as possible, and use the reconstructed coronary artery buttons to make up the new sinuses. In some situations, we will resect the tissue in the non-coronary sinus in order to reduce the root, and this is one of the technical considerations. And finally, to reduce the incidence of pulmonary stenosis, we tend to close the main pulmonary artery and move the reanastomosis of the main pulmonary artery further leftward into the left pulmonary artery by doing a Lecomte. So some of the technical considerations that I've sort of considered to be important, and I'd love to hear what other people think about that. In terms of what are the long-term issues, and how does that then come back to help us modify what we do at the time of anatomic repair? Well, clearly, these are some of the issues that we face. Systemic venous baffle obstruction with the mustard we just spoke a little bit about. Pulmonary venous obstruction can occur with ascending, and part of the reasons why I like to use the mustard type reconstruction for the atrial switch. We talked a little bit about the aortic root dilation, the aortic insufficiency that comes with that, monitoring the coronary arteries to ensure that we're not developing occult coronary artery stenosis, which could be some of the etiology surrounding the LV dysfunction that we see late afterwards. Heart block is a big concern, and we'll talk a little bit about. I think the left ventricular dysfunction, as was mentioned by several of the speakers earlier today, is disconcerting. That's something that we cannot fix as surgeons. And once you've done an anatomic repair, there are very few options for treatment once this has occurred. And then pulmonary artery stenosis. So when we talk, I want to talk a little bit about our outcomes with the double switch, and Dr. Reddington earlier alluded to some of this in his talk. And I think, in my mind, clearly the most disconcerting finding was a 7% incidence of left ventricular dysfunction. And I would like to kind of talk a little bit about this, because to me, this is not something that obviously precedes the double switch operation or the anatomic repair. We don't see this coming. We do an operation, and then years later or months later, we may detect this bobble. And had we known that this is going to occur, we might not have even selected selected that strategy. I will point to a 6% incidence of baffle reintervention. Again, we're doing things to try to prevent that, and perhaps it's not as consequential of a complication compared to left ventricular dysfunction, but it certainly merits further examination. In this series, we did have about a 4% incidence of neo-aortic insufficiency, and then Dr. Rankin really alluded to the 27% incidence of CRT pacing, and I want to delve a little bit into that in just a second. But before I move on to that, again, preventing pulmonary vein stenosis is of paramount importance. If you do a ascending type of reconstruction, some of our surgeons in Boston have traditionally done, there are modifications to this technique to prevent obstruction of that pulmonary venous confluence as it exits. And this is an example, Schumacher modification, and there are other modifications that help expand that. I mentioned earlier use of a tube Gore-Tex graft to retain some of the shape of the mustard reconstruction, which I like to do, and I found has reduced my incidence of SVC or baffle obstruction. Now, getting a little bit into the etiology of left ventricular dysfunction after anatomic repair, we looked at histologic specimens of normal hearts and then compared them to patients who underwent pulmonary artery banding and ultimately didn't survive or had a transplantation. When we looked at the histologic sections, what we found was kind of interesting. That is, if we look at the subset of patients with intact ventricular septum who underwent pulmonary artery banding, here, this second row, compared to normal, there was clearly a difference in capillary density between those two populations. You can see here on the right the histologic specimens. In this top panel, this is the normal heart specimen, and you can see the capillaries here. On the right, on the top right, is the intact ventricular septum patient who's underwent a pulmonary artery banding. You can see clearly there's some myocyte hypertrophy, and importantly, the capillary density has not increased to keep up with the hypertrophy. On the bottom panels, you see patients who had some degree of naturally occurring outflow tract obstruction. Native pulmonary artery stenosis with a prepared or high-pressured left ventricle. And there again, you see that their capillary density matches the normal population. So there's a hypothesis brewing in Boston that perhaps this capillary density issue contributes to some of the late dysfunction that occurs after an anatomic repair, particularly in those patients who've underwent retraining with a pulmonary artery band. And I think speaks to some of the discussion earlier about being very careful about overbanding. And it may not have to do with acute death of the ventricle, as Erwin had alluded to, but perhaps it could also due to the hypertrophy that occurs too quickly and outstrips the blood supply of the capillaries. Food for thought, not solid data yet, but it's at least a beginning to help us think about how we manage these patients. I want to shift for a second to talk a little bit about the occurrence of heart block in CCTGA. Some of this is surgically induced, and some of it is just a natural history over time, but clearly has an impact on survival and health of the patients over time. When we looked at our risk factors for left ventricular dysfunction, we indeed found that the presence of heart block, or the development of heart block, or the need for a ventricular pacemaker in the perioperative period was associated with eventual LV dysfunction. And the prolonged QRS duration, even in patients who did not have a full heart block, also was associated with left ventricular dysfunction. This got us really thinking about the role of electrical stimulation, electrical conduction on LV dysfunction in the long run. And it is, again, one of these not fully tested, but gestalts that perhaps the progression in conduction abnormalities precedes and may actually contribute to LV dysfunction. Part of the reason why you're seeing a lot of CRT device placements in Boston, we tend to be very aggressive about doing a CRT pacemaker for patients who are developing ventricular dysfunction, and particularly any patient that needs a pacemaker gets a CRT device. It's not a straightforward where do you put the leads discusussion, but that's something that we've been thinking a lot about as well. What we've found interesting in a very small subset of patients, that the patients who undergo CRT device placement as their primary pacemaker, if they develop heart block, did not have the same degree of ventricular dysfunction compared to those who have traditional pacemakers. So needless to say, let's leave it at there seems to be some relationship between the rhythm and the development of LV dysfunction. It's hard to know which comes first, chicken or the egg. Nevertheless, this has prompted us to take an approach during an operation for closure of the VSD in patients who have VSD to map the electrical system in the operating room. Here you can see the bundle of His located just proximal to the ventricular spike. We do this in all of our patients now who have a VSD closure to identify the precise location of the conduction system. And Dr. Cook earlier had kind of given you a very general idea of where the conduction system generally is located in these patients. But I will tell you, having done this now in at least 20 patients, that the location of the conduction system is not as consistent as I would have thought. And we're starting to map on the left side of the ventricular septum, on the right side, to help us really determine where to place our sutures. And in very anecdotal experience so far, I think has reduced our incidence of complete heart block, and hopefully will improve our QRS duration for the remaining patients, and so on and so forth. So here we're really looking for the bundle of His, we're looking for the distal bundle, and we're looking to avoid suture placement by placing the sutures more in the area where there are normal ventricular spikes. More to come on this, something that's that we're doing more recently in this patient population. Finally, I want to talk a little bit about the management of tricuspid regurgitation in patients who have tricuspid regurgitation at the time of anatomic repair. Here you can see in this flow chart that we had about, of our 100 patients, we had about 24 who had some degree of tricuspid regurgitation, and in a fair number of those patients, the regurgitation gets better just with anatomic repair alone. And so not every patient needs tricuspid repair. Having said that, there are a fair number of patients that we do address the tricuspid valve at the time, and this is typically with just an anoroseptal commissuroplasty, and again, in patients who did not have this anoroseptal commissuroplasty, there were a small number who did develop progressive tricuspid regurgitation, and in some cases required reintervention. So I want to conclude, since I want to leave some time for discussion, to really emphasize the lack of clarity regarding the best approach to CCTGA, despite our institutional bias towards anatomic repair in these patients. If you're going to do an anatomic repair, it may be better to move at that on the earlier side, just because there may be a relationship between the two. And perhaps some of this has to do with the capillary density phenomenon, particularly in those patients who have intact ventricular septum. We are keeping an eye on the left ventricular dysfunction. It does bother us, and I think that part needs to be better sorted out. I mentioned some of the technical modifications that we have adopted to try to reduce the complication rates, particularly related to complete heart block and baffle obstructions. But I do feel that we feel fairly confident that in a patient with CCTGA, if a pacemaker is necessary, it appears that a CRT device is preferable. We're trying to use some of our mapping to help identify the optimal location of devices, and I certainly look to others in your group to get your perspective on how you see anatomic repair and some of these challenges that we face with this patient population. So with that, I'd like to end my talk, and I want to thank all of you very much for the opportunity to speak to you today.
Thank you, Ram. That's excellent talk. Thank you. And I think it underlies really, I think, what a achievement is to get results like that at the double switch. It's not easy. It's a very challenging technical procedure, and the patient selection and the fact you've got accumulated so much experience, I think, is a real credit to you, and it shows what can be achieved, I think, for the anatomical repair, which is kind of where we are, you know, what we're here for today. I guess, I mean, my first question is obviously is this whole business about the age, about retraining, and you've got some good evidence there showing how we can be smarter about training, as Andrew Eddington said sooner, but still the age thing, I think, worries us all. I think I was interested that in your earlier sort of papers, you'd suggested that there really was perhaps the age around 2 or 3 years that was the best outcomes, but it's not perhaps so obvious looking at this larger series. Is that right?
Yeah, I think there's clearly heterogeneity in response of patients to this, and I think it's got to come down to a myocyte level analysis, and I think that's why we've started to look a little bit at the histology of these specimens, and I wonder if one can use with either some form of proteomic or omic analysis, a patient-level biological response to that afterload. And if that is more predictive of what the pressure volume loops are going to show us, and how a patient will ultimately then respond to an anatomic repair, it's purely speculation at this point, but I do feel that a patient that I would not have expected a pulmonary artery band to lead to a meaningful hemodynamic response in a patient with a really thin LV that I'm taking to a band, it's older age. I put a band on saying, okay, we'll see what happens. And we come back in a year or two and LV looks great. Likewise, a patient with a really nice ventricle at a young age goes to a pulmonary artery band and doesn't have the response that we're looking for. I haven't been able to really tease that out, other than to say we need to be looking at it carefully. Don't give up on it, but know how to assess preparedness and know how to optimize preparedness with not only afterload, but also volume loading of the ventricle.
Yeah, and Mike C is asking in the chat, how about LV mass? Do you find that useful in assessment?
You know, and when we looked at our most recent series, we didn't actually find that to be a predictor. Now, I will say that because we do use that informally as a selection criteria, we may be selecting out patients who did not have adequate mass. So we may not have the full spectrum, but within that range of LV mass that we saw in those patients in the retrospective study, we didn't find a dose response.
Yeah.
I don't think that means that LV mass doesn't matter. I just think that we may not have teased that out. It's an excellent question. We still look at it. It's hard not to.
Yeah. A question from Dawood Kamal in Pakistan, and again, I think this alludes to some of your comments in your paper. What do you feel is your current policy if you have a young child, so maybe under 3 years of age, who really has good intact septum, but with no TR and well-preserved RV? Do we just watch them?
Well, the cardiologists try to hide those patients from us, but I have to say that I didn't show the slide because the numbers were really small when we teased out the corrective transposition intact ventricular septum with good ventricular function and no TR. There wasn't a difference, and when we looked at that small subgroup of patients between the curves on Kaplan-Meier analysis. So I would have to say that that is clearly a population that one could argue we should just be observing. Having said that, our approach is to be fairly aggressive about at least banding and assessing preparedness, and we tend to have a higher bar for going to the double switch. I want to make sure that all of our parameters are a go before we go to the double switch, but we do still prefer anatomic repair in that subset of patients.
Yeah. In those, and just going back to the older ones, you don't feel in your heads you've got an age cutoff necessarily if the ventricle's responding well to the band. We don't. I can pull back one of the to that slide, but we had several patients who were older than 10 years of age. Not many. There were a couple that were older than 10 years of age who actually went to an anatomic repair. And actually, one of our 14-year-old patients at the time of a double switch operation is one of our healthiest and has good ventricular function. So starting to get down to anecdotal here. So I want to be careful about being really dogmatic about it. But I think our strategy has been to really assess response, and that's true whether we're talking about biventricular repair and staged ventricular recruitment, and it's the same when we're thinking about a patient with CCTGA. We want to know what the LV can do, and let's tailor our approach based upon that response. And if we can get the right tools to assess response, then I think we can really have a nuanced discussion about who should and should not be going more. It's more precision medicine type of approach rather than demographic based approach, looking at the individual patient's response. Thank you. There's a question in the chat around the EP mapping in the OR. Saying, firstly, how do you get the whole EP kit in the OR to do it? And what are the sort of range of or the surprises that you've found? Are you seeing double loops, or are you seeing conduction reverting to the normal position unexpectedly?
Great question. So in terms of the logistics of it, it's actually relatively simple. We have a mapping system on a cart that our team brings down to the operating room. One of our electrophysiologists will be in the room when we're doing the mapping. We do have to fibrillate the heart. We want to make sure we don't get air embolus with competent AV valves. So we're very careful about avoiding air inside the heart when the heart's beating. So we fibrillate, open the heart, frustrate the valves, then defibrillate. And then with the beating heart, we can start to map in different locations. I'll typically open both the right atrium as well as the pulmonary artery, so it can map through both the atrium and the pulmonary artery, which would be the neo-aortic outflow tract. And then we put the catheter on all sides of the heart where we're planning to place either the septal defect, or in patients with severe pulmonary stenosis, if we want to do a root translocation, I want to know if there's something underneath the aortic valve. And I've been surprised at the variability in location. you'll often find it on the left side of the VSD. That is, you're looking in, it's right there. That's where we tend to place our patch. Some people like to place the patch more on the right side of the ventricular septal defect. So if I see it more on the left side, I'll place my sutures under there. It's a little bit harder to get underneath the VSD in that situation, but it's worth it if you can avoid the conduction in that situation. Now, sometimes it's located more on the right side, and so I place my patch more on the left. In the areas where I identify conduction system, and if I'm going close to that, I'll take very thin bites. I'll almost risk having a residual ventricular septal defect in those areas by taking ultra thin bites and trying to go further out or further in, depending upon what the mapping tells us. It remains to be seen as to whether that really prevents the long-term incidence, but I do feel in some patients we kind of get close to the conduction system with our sutures, and that may not lead to immediate heart block, but down the road may contribute to the development of heart block. So we're further investigating that. We're trying to put together an atlas, a library, to kind of show some of the variability, heat maps, if you will, generally where has it been located in our patient population. So, and for people that are interested, I think a center like yours, if you're interested in doing this, we would love to collaborate on this effort, because I think that we can certainly learn a lot with larger number of patients and your expertise as well. So an open invitation to sort of collaborate on this exciting new project.
Well, thanks, Ram. There's several questions coming through about sort of how you decide the timing of the double switch after you've been banded. How long do you wait? What do you look for?
Yeah, so we will tend to bring patients back for echo at least every 6 months. We want to be careful about ending up with suprasystemic left ventricular pressure. We've had a few patients that are not from Boston, gotten lost to follow-up, and in the setting of an intact ventricular septum have come back with suprasystemic left ventricular pressures and left ventricular hypertrophy, and we've been concerned about that. So we tend to make sure that we're seeing them at least once a year for conductance catheter in the cath lab, as well as an MRI cath, and we're looking for LV pressures that are at least 3/4 systemic. We're looking for end diastolic pressures that are at least in the high single digits, potentially low double digits, but preferably the low single digits. And then we'll look at the LV mass, although we're less likely to use the LV mass to make a determination. Predominantly using hemodynamics, and now starting to see what the conductance catheters and pressure volume loops will tell us about the behavior over time, looking at the DPDT there, as well as some of the passive and active relaxation characteristics. I can't say that there's a cookbook formula, but we really take all of these into consideration, as well as sort of the urgency of that patient. Other reasons to proceed sooner with an anatomic repair might affect that decision making.
Well, thank you. And so now a question from the UK, from Karen Van Dorn, asking if you had a patient who's got heart block and needs an epicardial pacing system, but they've got completely normal RV function and OTR, would you still band them at the same time?
We certainly are big proponents of pulmonary artery banding in a patient who's presenting with heart block, if they have morphology of the left ventricle of a right ventricle that looks like it's going to head towards dysfunction, dilated, septal shift, things of that nature. We'll be more aggressive with pulmonary artery banding at the time of pacemaker. I assume we're talking about a patient who hasn't had a who has a physiologic circulation at this point. We will do a pulmonary artery band in that patient.
Okay, and one more question about, yes, the histology is interesting, and the capillary density, but it's a question asking, do you know of any histology that's been done maybe in older adults with CCTGA, and whether it's demonstrated a difference in capillary density or myocardial density?
Yeah, that's a great question. So there weren't very many patients in this particular series with the banding that were older to show that that's the case. But certainly in patients who have had ventricular dysfunction in the right ventricle, the systemic right ventricle, for other reasons, we sort of find the same issue. So this is something that we're still trying to tease out. So we're thinking about not only the CCTGA patients, but the systemic right ventricle and single ventricle. Could this be part of the disease process as well? We're also trying to think about ways to measure capillary density without a pathologic specimen, because obviously if you want to use that to manage a patient, are there ways of doing it short of a myocardial biopsy? And there are some interesting technologies available that may be able to help with that, some optical based technologies, fluoroscopy or angiography with looking at density, contrast density. So there are some other techniques that may be useful, and we'll see if any of these turn out to be predictive.
Thank you very much. It's really interesting. I say thank you again, and congratulations on the outcomes and for what you've published, because it's very helpful to all of us. So thank you so much. We're going to carry on, and we'll pass over to John Coles, who's going to introduce our next invited speaker, which will again elaborate on perhaps pushing the boundaries for anatomical repair.
Go ahead, John.
Great. I think we're okay. Well, welcome to the Michael Brotto lectureship. Dr. Brotto, many of you may know, was born in Johannesburg, South Africa, and studied medicine before pursuing further training in Edinburgh, Scotland. He went on to serve as chief resident at Boston Children's Hospital. Dr. Brotto came to Toronto in 1958 and spent 40 years as a staff cardiologist at Sick Kids and associate professor in pediatrics at the University of Toronto until his death in 2008. Several of you in the audience today remember Dr. Brotto as a skilled and compassionate clinician. I certainly remember well myself that Mike was a very energetic supporter of his colleagues, staff, and advocate for the trainees. Mike was very generous, and he left significant gifts through his estate to Mount Sinai Hospital, the McMichael Canadian Art Collection, the Art Gallery of Ontario, and the Toronto Symphony Orchestra. So in celebration of Dr. Brotto's legacy, it is a pleasure for me to introduce our guest speaker, Dr. Olivier Raske. Dr. Raske is a prolific surgeon innovator who is globally famous for his work in CCTGA. And of course, that's why he was invited here. But apart from that, his resume shows that he has made wide-ranging and novel contributions to the field of congenital heart disease. For example, in autologous tissue reconstruction of the right outflow tract, 3D coronary reconstruction after arterial switch, repair of AVSD with double orifice left AV valve, and in many other diversified topics. Dr. Raske is professor of surgery at the Necker Hospital at the University of Paris, and no doubt Mike Brotto would be very proud that his legacy could provide an opportunity for this conference to learn from such a distinguished thought leader in the surgery of CCTGA. Dr. Raske's presentation today will address the dynamic topic of pulmonary artery banding and double switch operation. Welcome, Olivier. Welcome to Toronto, so to speak.
Thank you. I think you have my pre-recorded presentation. Yeah, thanks. Hello to everybody. First of all, I would like to thank you, the organization committee, for their invitation. It's a real pleasure to speak and share our experience on this difficult topic, which is CCTGA with intact septum. I changed the title. It was written Prophylactic Banding and Early Double Switch, and I would like to say that the concept developed in Paris was not to do a double switch for any patient, but to offer the possibility of doing a double switch in case of an unstable clinical status on patients who had benefited from a PA banding. Last but not least, the strategy that has been developed in Paris is very controversial because we decided to treat people who were not sick, but we have this data now, and it's very important. It is a very important data and give some answer about the morphologic left ventricular retraining. So even the strategy has probably evolved in Paris. It's important again to keep publishing on this cohort of patients that give some answer to the question that are asked in this field of CCTG. So the title of this talk is Early Prophylactic PA Banding in Isolated CCTGA or CCTGA with Intact Septum, a winning strategy. If you look at the medical literature, this is very easy to find a publication that report survival of patients with CCTGA with intact septum up to 70 years, 80 years, or even 90 years of age. But there are very few cohort of patients to know the natural history of these specific patients. But the natural history of CCTGA with intact septum is not a long and calm river. Even if it's a rare situation, we know now that the systemic morphologic right ventricle can lead to a dysfunction and failure of the right ventricle and the appearance or worsening of the tricuspid regurgitation, two elements that can lead to a heart failure later. Despite the possibility of congestive heart failure, it's true that the survival of CCTGA with intact septum is very high and really better than CCTGA with associated lesion. This paper published in 90 from the Brompton Hospital pointed out the excellent survival of this subgroup of patients compared to the one who needed surgery due to associated lesion. But it has been confirmed in a more recent study. This series from two major centers in France, Lyon and Lille, showed, and it's unpublished data, that the long-term outcome in terms of survival of a CCTGA with intact septum is quite good, even not free of death or risk of transplantation. So the survival is excellent, especially before the age of 30, but this is not the only point of the outcome of this patient. If you look now at the outcome in terms of heart failure, the situation is not so enthusiastic. We can see on this graph that patients with CCTGA with intact septum who didn't benefit from any aggressive treatment present a risk of heart failure of about 30% at 40 years. Of course, it's really better than CCTGA with associated lesion, but far away from being perfect. If we concentrate now on right ventricular dysfunction, it's getting worse and worse a long time. At the age of 40, there are about 40% of the patients who had a severe or moderate right ventricular dysfunction. Of course, it's better again in the CCTGA with intact septum compared to the one who have associated lesion. And if we believe in the French registry on CCTGA with intact septum, one can see that there is not much improvement despite the improvement that have been done in medical therapy for cardiac failure. So they do experience cardiac failure at the age of 30 and 40, and it hasn't changed for the last 20 years. So these patients are exposed to a significant risk of right ventricular dysfunction and heart failure, but electrical complication as well. This is again the data from this French cohort of patients that shows a very high risk of AV block, arrhythmias and pacemaker implantation during their life. And at the end, if we look at the curve of freedom from the most frequent complication, I mean cardiac failure, arrhythmias, AV block, death or transplant, it's really far away from the ideal situation. And finally, at the age of 40, you have only 40% of the patients who are free from this major complication. All these complications, especially the morphologic right ventricular dysfunction, result in a slow deterioration of their clinical status. So the picture of a 70, 80 years old patient who is diagnosed incidentally on a chest X-ray is far away from the reality. And when the patient becomes symptomatic at the age of 30 or 40 years old, the therapeutic options are limited. But if you see the age at diagnosis, which is made earlier and earlier, with a quarter of patients diagnosed antenatally and 2/3 before any symptoms, it gives probably the possibility to offer therapeutic option before the appearance of symptoms, particularly if you take into account that when older patients become symptomatic, the therapeutic options are sometimes limited. This is why Professor Daniel Sidi, who was at the head of the cardiology department in Necker, developed the concept of an early PA banding. He has observed that the natural history of the CCTGA with intact septum and pulmonary stenosis was better than the one who didn't have any stenosis. At the same time, we had more and more publications saying that the fate of the retrained morphologic left ventricle was not as good as expected. So they had this debate in Necker Hospital in 2000 for CCTGA patients with intact septum. A prophylactic approach versus a curative strategy. Should we wait until the patient becomes symptomatic and can benefit from medical therapy, late PA banding for reconditioning, or tricuspid surgery or transplant? Or on the other hand, go for a prophylactic approach with PA banding in childhood to preserve LV and avoid TR. Since 1998, Daniel Sidi was really convinced about the preservation of CCTGA by pulmonary outflow tract obstruction. Even the data was very weak at that time. This data came later from the Levin group, showing that pulmonary outflow tract obstruction protects against tricuspid regurgitation, right ventricular dysfunction, heart failure, death, and transplantation. And there was a correlation between the severity of the stenosis and the protective effects. This is why we wanted to mimic that protective effect by doing PA banding at a very, very early age. At the same time, there was more and more evidence that the fate of the morphologic left ventricle was better if the patient didn't need any retraining, or this retraining was done as early as possible. Even no clear cutoff was defined, 15 years, 10 years, 2 years, but earlier seems better. So the better morphologic left ventricle outcome for the youngest patient is probably explained by the fact that the pressure overload greatly promotes proliferation of ventricular cardiomyocyte for the younger patient. For older patients, hypertrophy and fibrosis are usually a consequence of this afterload increase. This is now extremely clear for neonatal heart in experimental model, and these findings support the concept to perform an early PA banding if you want to preserve the morphologic left ventricular function. So the concept which has been developed in neck care wanted to avoid the shift of the septum by elevating the LV pressure to decrease the incidence or severity of the tricuspid regurgitation, but also to allow the late use of the morphologic LV in a systemic position if needed, I mean in case of failure of the systemic right ventricle. At the same time, we wanted to preserve the morphologic left ventricle rather than doing a retraining, because it might avoid the LV dysfunction after retraining and subsequent double switch. This is very important to keep in mind that the double switch is not the final objective. The main goal is to keep the morphologic left ventricle at systemic pressure in order to be in the best cardiac condition, but also allow a later double switch only if needed. This is why we have used partially adjustable PA band in order to be able to dilate the band during the growth of the child, just to keep the LV pressure at systemic pressure. Olivier Raske proposed in 2012 an enhanced LV retraining by creating an ASD. So you add a volume overload to a pressure overload. We didn't adopt that strategy for our cohort patient, probably because it was more a strategy to preserve the morphologic left ventricle than retrain it. And the second thing is that we didn't want to create a strong adhesion around the heart by doing the ASD. It could be done, of course, for a neonatal patient by a Rasking procedure, but to be honest, after a few years, we have seen that all the patients had a morphologic left ventricle which was able to sustain systemic pressure. I'm going now to share our experience in neck care hospital with early prophylactic pulmonary artery banding in CCTGA with intact septum. We published a very limited cohort of patients in 2009, and we are almost ready to submit a manuscript now with about 45 patients. So between 2001 and 2019, 43 infants, all less than 1 year of age, have been operated in the unit, and about 50% of these patients were neonates. For the CCTGA, 31 had an intact ventricular septum and 13 a very restrictive VSD. Median age and weight at pulmonary artery banding were 32 days and 4 kilograms. 8 patients had a grade 2 or grade 3 tricuspid regurg, but only 3 patients were symptomatic. So the surgical technique to do the PA banding is quite easy. Here it is a a PEA band which is applied for multiple VSD, but the technique is the same for the CCTGA. So we do a sternotomy, a very limited pericardial opening, and then a PEA band is tailored in a 0.6 mm PTFE patch with about 3 mm width. The circumference is correlated to the age and weight of the newborn or infant. We do a TOE and a pressure gradient in order to obtain a 50% of systemic pressure. The distal placement is achieved in order to avoid future aortic valve damage, and a series of 6O are applied on the distal part of the PEA band in order to adjust later by balloon angioplasty. After a learning curve now, we have more experience in this prophylactic PEA banding, and the optimal circumference for neonate is about 20 mm plus 1 mm per kilo per weight. This series of 6O proline, which has added at the distal part of the PEA banding, allows us to have a dilatable, partially adjustable band, and in case of suprasystemic morphologic LV pressure, we will be able to adjust this band by balloon dilatation. The median follow-up is now 9 years. We didn't have any early mortality. The ICU stay was 4 days, and the hospital stay 6 days. There was a longer ICU stay for the infants compared to the newborn. Inotropes were needed for 1.5 days. There was short ventilation need, and we did have a few complications as mediastinitis. We have seen that we needed more inotropes for older patients, but also more inotropes in case of tight pulmonary artery bunding. There was again a correlation between the initial band velocity and the PEA band circumference weight ratio. The patient had a repeated echography in order to measure the mean band velocity. The initial velocity was quite low, and it's true that one could argue that it was more a retraining than a preservation, but you can see that this velocity increased quite quickly after the initial PEA banding. There was a slow and constant increase of the velocity, and the band velocity increase of 1.85 per meter per second per year. The mean band velocity increased over time from 3 meters per second postoperatively to 4 and 5 at 6 months and 5 years. The mean follow-up is 9 years now. Very importantly, 2 patients died after PEA banding at 4 months and 1 year. The first death was labeled as sudden death infant syndrome at necropsy. The patient has been seen on clinic 1 week before. He had a peak gradient of 40, a mild TR, and no problem of conduction. The second death was secondary to progressive refractory biventricular dysfunction. The PEA band was very loose, and he benefited from a tightening of the PEA band, but both ventricular function didn't improve and died subsequently. If we try now to analyze the effect of the early PEA banding on tricuspid regurgitation, we had the impression that there was a significant decrease of TR. 6 out of 7 patients with moderate to severe TR had a reduction of the severity of their regurgitation. 2 patients had persistent TR, and at last follow-up, 93% of the patients didn't have any significant tricuspid regurgitation. The effect on the right ventricular failure is more difficult to evaluate because only 3 patients had a significant right ventricular dysfunction. 2 patients with moderate systemic right ventricular dysfunction recover a normal function, and 1 patient with a normal morphologic right ventricular function developed this refractory biventricular failure. MRI study has been performed for 15 patients at a mean age of 5 years. We didn't observe left ventricular or right ventricular dysfunction, no dilatation, no significant TR in these 15 patients. The ejection fraction for the morphologic left ventricle or morphologic right ventricular were very close, around 60%. The mass of the morphologic left ventricle was 30 grams per meter square and 40 grams for the right ventricular. We did have a very weak correlation between the PA band velocity and the LV mass on MRI study, especially for the youngest patient. We didn't observe any fibrosis at MRI study, even for the oldest patient. The mass ratio between the left and the right ventricular was around 0.75%. Most of the MRI study has been done while the patient has achieved a PA band velocity around 5 meters per second. Reintervention has been necessary for 10 patients, including 3 percutaneous PA banding dilatation at the age of 4, 7, and 8 years for suprasystemic morphologic left ventricular pressure. This patient had a suprasystemic morphologic left ventricular pressure, but with a perfect morphologic right ventricular function and no tricuspid regurgitation. 7 patients benefited from a double switch around the age of 7 years old. Indication was 2 suprasystemic morphologic left ventricular pressure, 3 AV block, 1 severe TR with moderate right ventricular dysfunction. Freedom from double switch was 100% at 1 and 5 years and 75% at 10 and 15 years. The immediate postoperative course was uneventful for these 7 patients. Unfortunately, 1 patient died at 5 months, waiting for redo surgery for a pulmonary venous obstruction. At necropsy, this patient had a shrinkage of a decellularized patch that we have used to enlarge the buffer. All patients benefited from regular echo and MRI study. And at last follow-up, we didn't observe any morphologic left ventricular dysfunction, no aortic regurgitation, and no tricuspid regurgitation too. So what did we learn from this initial experience? First of all, the early PA banding isn't correlated with a high morbidity and mortality. Even 2 patients died, but it's difficult to relate the observed mortality to the initial PA banding. We didn't observe any PA bifurcation distortion despite the need of a distal PA banding, and we obtained a significant reduction of the appearance or severity of the tricuspid regurgitation. We have seen a couple of patients who did improve their morphologic right ventricular dysfunction, but it's difficult to make any conclusion on this specific topic. Very importantly, after 5 to 7 years, the morphology left ventricle seems to be adequately conditioned for a systemic afterload. And no late morphologic left ventricular dysfunction has been observed at last follow-up, after PA band and after the double switch when it was needed. There was probably some modification during this early experience, and the strategy has probably been adapted during this last 15 years. Nowadays, the policy is to do an early PA bonding within the first month of age. The indication for double switch is quite clear now. AV block with conditioned morphologic left ventricle. It means that the morphologic AV pressure is up to 80% of the morphologic right ventricular pressure. We go for double switch in case of moderate to severe TR and in case of morphology right ventricular dysfunction. Indication for PA balloon bonding adjustment is isolated suprasystemic morphologic left ventricular pressure. But of course, you can get complication during this procedure. Aortic valve can be damaged, long period of bonding and the risk of a dilatation. And of course, you always have the risk of AV block. Last but not least, the double switch is easier around the age of 5-6 years old, and we are a bit concerned about delaying the double switch. But we really think that this patient can be very stable with morphologic LV pressure at a systemic level without the need of a double switch if the morphologic right ventricle has a good function. In conclusion, I would say that the mortality is really a matter of concern in this very controversial series, especially the death that happened after the double switch operation, and which is directly linked to the strategy that has been adopted in the unit. We didn't show any evidence of any benefit with such a short follow-up because I would like to remind you that patients become symptomatic usually after 30 or 40 years. The double switch and its potential early and long-term complication will give the answer for real benefit. But we have already shown that we didn't observe any morphologic left ventricle dysfunction after the double switch or after the PA bonding. This series is of course very controversial because we decided to treat people who were not sick and probably not sick before the age of 40 or 50 years old. It would be great, of course, to try to detect a subpopulation of high-risk patients, but they need to be treated with this technique very early in VH, and it's probably more than difficult, actually, to know the one who will develop a morphologic right ventricular dysfunction or a tricuspid regurgitation. I would not hesitate to do the promotion of early PA bonding in the neonatal period or for infant in case of tricuspid regurgitation, moderate morphologic right ventricular dysfunction, and some patient with a VSD with low pulmonary artery pressure but a significant shunt, and probably also for patients who had developed an AV block. We have shown that this patient will benefit from an early PA bonding in terms of tricuspid function and a morphologic right ventricular function. There is of course a gray zone for the perfect CCTGA with intact septum, and I would not advocate at this time to systematically do an early PA bonding for this subgroup of patients. Thank you very much.
Okay, we'll go ahead with the questions. Thank you, Olivier, for a very interesting and provocative talk. There's certainly evidence in the literature that the stem cell compartment is very robust in the first 6 months of life in the neonatal period, and then after about a year of age, it declines fairly markedly. So that accords very well with your rationale for doing early PA band as early as a month, I guess, is your preferred time window. I was interested that you commented on cardiomyocyte proliferation, because we see that in the neonatal period in response to stress. And again, like the stem cell dynamics, that declines fairly rapidly, again, supporting your approach. And so I think cardiomyocyte proliferation, in addition to capillary density, as mentioned by Dr. Amani, is an important metric. I was a little bit surprised that your preferred interval is 6 to 8 years after the early PA banding, and the audience may be interested to know what is the risk over that time of developing LV dysfunction with a long-standing band, and the risk of, for example, cardiac fibrosis.
Yeah, we had 2 patients who were lost of follow-up for some time, and it's true that when the pressure in the morphologic left ventricle becomes very systemic, I mean, there were a huge hypertrophy, and one patient probably developed some fibrosis. Anyway, this patient has been dilated a few days ago, and he experienced a very difficult cath lab period, because I mean, it was so unstable, had a ventricular tachycardia. So of course, what we want to do is to keep the morphologic left ventricle at systemic pressure and not suprasystemic. And I think usually the period they get suprasystemic is around 7 years old. So you need to have a very close follow-up in order to adjust the PA band, which has been done quite easily, I mean, in CCTGA in our experience, but also in other indication as multiple VSD or complex DOVE. So I think you have to be very careful not to keep a patient with a suprasystemic pressure.
Yeah, so we had a related question from David Barron about the percentage risk, accrued risk of needing to proceed with the double switch because of suprasystemic LV pressures. I think you've touched on that.
Yeah, I think, I mean, all patients will become suprasystemic at some times. What we have seen is between, I would say, 6 to 9 years old. And I mean, we have to understand that we don't want to offer double switch for all of these patients, because we would expose them to probably a significant risk during the surgery and during the post-op. So the idea is to keep the morphologic left ventricular pressure at systemic pressure, but not systematically do the double switch. I'm sure that if we keep them with a very tight band, I mean, they will get some problem. I mean, and they will definitely get some fibrosis in their morphologic left ventricle, and we won't get any gain in keeping that situation.
Thank you. And Dr. Seed is inquiring, do you use pulmonary artery banding in patients with CCTGA with larger VSDs as well? What's your preferred strategy in that situation?
I mean, for patients with CCTGA and large VSD, of course, we go for PA banding, but our strategy is to do the double switch between 3 years and 6 years, just for technical consideration. We think that it's easier to do a double switch at that age compared to doing the surgery at the age of 12, 15 years old, because I mean, the arterial switch, I think it's easier when they are younger.
Okay, and just another question that comes to my mind is, I don't think it's been discussed in this meeting yet, and that is the incidence and mechanism of neo-aortic valve regurgitation. Do you have any thoughts about what causes that?
Yeah, I can tell you that we were very concerned at the beginning of the series about getting aortic regurgitation after the double switch. This is why we put the PA banding very distally compared to what we regularly do for VSDs. One patient experienced an aortic regurgitation, moderate aortic regurgitation. It's the one who was lost from follow-up, and he has been operated. He was 9 years old. He had a moderate aortic regurg after the operation, but now at last follow-up, I mean, this aortic regurgitation has completely disappeared. What we have seen after the PA banding is that usually you have, we expected to have quite an enlarged pulmonary root, which will be the neo-aortic root, but finally it was quite tight, and it was easy to enlarge that root just by reimplanting the coronary button in order to treat the portion which is a bit stenotic after the PA band. So we didn't have the same impression as we have seen in our extensive experience in arterial switch for TGA.
Are there any other questions from the participants? I don't see any in the chat. David, do you have any?
John, I think there was a question saying, would there be a role for using bilateral branch pulmonary artery bands rather than a main pulmonary artery band to maybe reduce the risk of aortic valve distortion?
I really think it's not worth to do that. I mean, to adopt that strategy. I mean, the PA band, I mean, the distal PA band gives a lot of stenosis. It's quite difficult to deal with them. I mean, we know this, of course, in another situation with a hybrid procedure, but I would not recommend that. I think you can have a distal PA band, which is not going to damage the aortic valve. Even I know that a couple of patients needed to have a PA plasty at double switch. But you can, I mean, get a very good PA banding, and it's not exactly the same anatomic situation as a normal heart, where you can have a very stenotic right PA and an unprotected left PA.
Olivier, a question in the chat. When would you consider adding an ASD to the pulmonary artery banding for retraining?
I would say definitely not this for these neonates or infants. I think it's more for patients who are older. And of course, if we would have to retrain a patient who is 10 years old, we would consider this definitely.
And an interventional question, it looks like when the LV pressure is suprasystemic, how much do you dilate in the cath lab?
I don't know. I don't know how to reply to that question. But I'm sure that they dilate very progressively and then measure again the pressure in the morphologic left ventricle. So they take their time. They take a balloon with small diameter first and get bigger and bigger until they reach what they want to reach. I mean, systemic pressure. Of course, there is a risk of AV block, and I know that since we have collected that data, one patient experienced an AV block for a couple of hours. So it's, of course, a matter of concern for this patient.
So trial and error, the usual approach in congenital heart surgery. Patients with congenitally corrected transposition with intracardiac shunt and pulmonary hypertension with high pulmonary resistance, could pulmonary artery banding be a useful strategy?
We have never did this before. And I have no clear answer for this specific situation, to be honest.
I think that covers most of the questions.
Olivier, can I ask us one more thing about how do you approach the parents and the families if you're looking at a prophylactic plan and a newborn?
I remember that question at the BCC. To be honest, when I joined the team in 2006, and I was at the morning staff, and we had a PA bonding for neonates with a CCTGA with intact septum, and this patient was doing perfectly well. He didn't have any morphologic biventricular dysfunction, no tricuspid regurg. And I said, my colleagues are completely crazy. So at the beginning, but Daniel City was pushing a lot, I mean, to involve these patients. So it's always very difficult. I have to admit that it has changed for the last 15 years, especially since Daniel City is retired now. And since the patient who had a double switch died. So we were always saying that 99% of our colleagues in the world wouldn't propose a PA bonding, but we also explain what is the future of these patients. And we usually now see the patient, see the parents antenatally. And I would say that probably 3/4 of the patients don't accept the surgery, and we are quite happy with this. And we don't push too much nowadays for this very aggressive strategy. Of course, it's easier when we solve the patients with a moderate TR, or with a beginning of a morphologic right ventricular dysfunction. But when it's a perfect CCTGA, I mean, it's difficult to push them to go in this very controversial strategy with the data we have now. I mean, it's a risky strategy, definitely.
Thank you.
I think we might conclude there. Olivier, thank you for a wonderful perspective from Paris. And if you're going to be online for a bit, I might ask you just to have a look at the question and answer. There's a few that I think I overlooked that may appreciate your insight if you have a chance to do that. So with that, we'll conclude the Mike Brotto lectureship session. Thank you.
Thanks all. The next session is on imaging, and we'll start at 3:10 in Toronto time. So that's in about 30 minutes. Thank you.
From the coffee break. We are now going to proceed with our imaging session, and I have the great honor of introducing Adrian Sabo, who has been a pediatric cardiology fellow with us, an echo fellow, and a clinical and research fetal fellow with us for the past couple of years. She'll be moving on this summer to a faculty position at McMaster, just down the road. And she'll be kicking off an imaging session for us with the presentation of a case. Thank you very much, Audrey.
Oh, thank you, Lindsay, for the introduction. And thank you for allowing me to share the screen and this interesting case with you. Can you see my screen? It should be coming now.
Yep, we have it.
Okay, amazing. Just gonna put this. Okay, so first of all, please don't forget to join the poll. It's very easy and it's fun. It's very easy to join. Just scan this QR code or join go on the website, and please try and enjoy. So first of all, the aim of this presentation is to review a CCTGA patient with a complex course and the different management strategies, review of function of the individual ventricles, and also to review different factors in decision-making. A quick summary of this patient: he was diagnosed prenatally, was born term with an uncomplicated postnatal course, and he had a diagnosis of a CCTGA with primary VSD and abstenoid tricuspid valve with trivial TR at the time. and dysplastic pulmonary valve with a mild gradient, and had no rhythm disturbances. And he was stable after birth with no symptoms, discharged home after a few days of observation, and was doing just fine, and up until 2 months when he unfortunately developed tachypnea with work of breathing and feeding difficulties. I won't show the initial images as we have 17 years to cover, so we will just jump right into the middle of the event. So due to his heart failure symptoms, the decision was made to perform a physiologic repair at 2 months of age for symptoms of congestive heart failure. And after, this is his echo after the VSD closure during his follow-up. And this is an apical 4-chamber view where we can see the overall preserved function with severe tricuspid valve regurgitation. We can appreciate the dilated left atrium as resulted from the severe regurgitation, and the dilated systemic right ventricle as well. And here on the short axis, first on a long and short axis views, we can see this is the patch area of the VSD closure, and we can see that there's severe tricuspid valve regurgitation, and there's a volume loaded systemic right ventricle here. And here, this is the alveolative view from the apical imaging, and it shows an unobstructed pulmonary valve with a mild regurgitation and good left ventricle systolic function. So his clinical course after the physiologic repair, on the subsequent follow-up visits, he continued to have some mild persistent RV dysfunction with ongoing tachypnea, which was thought to be secondary to the increased tricuspid regurgitation. Therefore, he was initiated on a furosemide and captopril for afterload reduction, which resulted in slow improvement of his heart failure symptoms. And over the next few years, he continued on the same therapy and became completely asymptomatic with good exercise tolerance. But his echocardiograms showed ongoing severe tricuspid valve regurgitation, so he was having a relatively close follow-up to keep a close eye on that. This is his follow-up echo at the 7.5 years. And here on the 4-chamber view, we can immediately appreciate the severely dilated left atrium consistent with the severe systemic AV valve regurgitation, good left ventricular function, and the dilated systemic right ventricle with the borderline function in the context of this severe regurgitation. And we can see that this regurgitation is originating from this coaptation defect of the tricuspid valve leaflets. And here on the personal long axis and the short axis views, we can see how the systemic RV appears volume loaded, and the intraventricular septum is pushed towards the subpulmonary right ventricle. And as his clinical course continues, when we reached this follow-up at the 7.5 years, he started to have some occasional episodes of shortness of breath, feeling some extra beats, and there was this severe ongoing TR on the echo. So the time had arrived to consider an intervention for the long term, as having this degree of tricuspid regurgitation will eventually result in a burnout right ventricle and poor function, precluding the possibility of an anatomic repair anytime in the future. So we had to come to the conclusion that our patient had failed the physiologic repair strategy, and it's time to come up with a new plan. So here's the question for the poll. So what strategy would you choose? There's no right or wrong answer, as we all know that the management of a CCTGA isn't truly defined. So would you do a double switch operation at this point? Would you put on a band? Would you continue with medical management, or list the patient for heart transplantation? And this would be the ultimate solution anyways. So we're just curious what people think, and please go ahead. Okay. Yeah, looks like most of the people are leaning towards the PA band, which is very good news for us. As this is exactly what we did. So I can continue to show what happened. Okay, so the decision was made to put on a PA band on his main pulmonary artery to try to retrain the left ventricle, and also to shift the intraventricular septum towards the systemic RV to reduce the coaptation defect of the tricuspid valve and reduce the amount of regurgitation. And by doing that, to prevent the burnout of the RV. And doing all this with the aim to make him a candidate for possible future anatomic repair with a double switch operation. And after his PA band, it actually proved to be technically successful, where we achieved the desired septal shifting and the TR was reduced to moderate. And he was followed expectantly, and he was doing well for quite a few years with overall good RV and LV systolic functions. And he had 0 clinical symptoms. And when he was entering his puberty with expectant growth spurt, he was scheduled for a diagnostic cardiac cath to reassess the RV-LV pressures and the suitability for a double switch to make sure we wouldn't wait too long and burn out his LV as he grows, missing the window for a double switch. And we all know that the timing needs to be carefully managed here. And here we can see the echo from that time. This is the 4-chamber view showing overall preserved biventricular function with a moderate to severe TR. It's quite still substantial, but it's definitely less than before putting the band on. And we can see that the septum is shifted more towards to the systemic RV, and it appears to be less dilated. And the LVOT pre-gradient with the pulmonary band on it was 71 millimeters of mercury. And here on the short axis views, we can appreciate the overall preserved LV systolic function and a reasonable RV functions. So we had his diagnostic cath performed, which showed a 2/3 systemic left ventricle pressures, a well-placed but loose appearing PA band with some dilation of the central PAs and good biventricular systolic function. Therefore, the decision was made to wait until he grows into his band, as it appears to be loose. And his medications were discontinued at that time and remained well with good exercise tolerance. And the plan was to perform the double switch in case of a progressive TR, RV dysfunction, or developing of clinical symptoms. But we have to know that we're already at the 9.5 years of age now. And time just went by super fast, and we reached 14 years of age. And his echo at the time showed quite a reasonable RV systolic function in the setting of a severe regurgitation, moderate severe regurgitation, but now there is a reduced LV systolic function, which is a change from the previous studies. And here overall we can see that the RV function is preserved, as I said, in the setting of a severe or moderate severe regurgitation, but there is definitely a reduced LV systolic function with some hypokinetic anterior and lateral wall segments, and there was a mild mitral valve regurgitation at that time. We can see that the motion of the segments is definitely showing some dysfunction here. And his PA band gradient was 88 millimeters of mercury at that time. And this dysfunction is reflected in the TDI values as well, with the reduced systolic and diastolic values, as we can see here on the screen. And when we calculated the ejection fraction by Simpson's biplane method for the left ventricle, it showed 42% of ejection fraction, and the RV fractional area change was at 42%. He had some other tests as well. Exercise that showed good working and aerobic capacity, and the Holter didn't show any significant arrhythmias or ischemic changes. And there was a plan to perform a cardiac MRI to assess ventricle volumes and function and the presence and extent of fibrosis, but it ended up not happening for various reasons. But let's go through this here, as there are some important findings to note. So he developed a new onset of LV dysfunction, which is secondary to the PA band. And we have to note that there is no no hypertrophic response from the LV, and it's actually quite the opposite. The walls are thin with absolutely no hypertrophy, and this is a very concerning finding, as we see a systemic PA band gradient with decreased left ventricular function, and it's suggestive that the LV doesn't seem to be able to sustain systemic pressures. So most likely it would not sustain a double switch procedure and would have a high likelihood of LV failure after the procedure. So, and all this in a context of development of clinical symptoms with decreased energy levels, occasional shortness of breath, and palpitations. So there's a definite change of picture here. So now we have to say that our second strategy has also failed, and he failed the LV retraining as well. So we have to continue on our journey and figure out what else we can do. So that brings us to a question: what would you do? What strategy would you choose now? As you can see, again, there's no right or wrong answers, and there isn't a foolproof strategy to manage patients with CCTGA for sure. So what would you do now? Would you go ahead with a double switch operation? Would you loosen the BA band? Would you just do medical management and hope for the best? Or again, just straight go for heart transplantation? Let's see what people think. Okay, so it looks like nobody feels that he's a good candidate for a double switch. And there are some people who would straight list for heart transplantation, which is quite reasonable as well. And I can show you what we did. So we came to our number 3 strategy, and we actually decided to go to the cath lab and dilate the pulmonary band to relieve the LV afterload and promote the recovery of the ventricle. But there are some important new considerations that come with that. The patient is no longer a candidate for double switch operation, as the LV training has completely failed. So the RV will remain the systemic ventricle for the long run. So now it's even more important to control the severity of the tricuspid regurgitation and think about repair or replace the valve before there is deterioration of the RV function, as we know that the systemic RV doesn't like the volume overload on the long term. And but thankfully, the patient was feeling much better after the intervention with improved exercise tolerance. His LV function recovered nicely, but his tricuspid regurgitation remained severe and increased over the course of just 2 years, as I will show you. And at 17 years was when things have really started to go downhill, and he presented with severe congestive heart failure symptoms with significant exercise tolerance, dyspnea, abdominal pain, decreased appetite, and weight loss. And no need to point out here on this 4-chamber view how dysfunctional this overloaded systemic right ventricle is, with a torrential tricuspid valve regurgitation and an extremely dilated left atrium. And here we can see that the LV function is reasonable or mildly reduced, and there's a severe coaptation defect resulting in severe tricuspid valve regurgitation, the severe RV dysfunction as well. So, and the left ventricle, as we can see it here in the LV 3-chamber view, there's no outflow tract gradient at all, and the LV function is reasonable. So strategy number 3, we have to say that it also failed, and the debanding resulted in progressive tricuspid valve regurgitation and the quick burnout of the right ventricle. And I just put this out here. What would you do? We have to realize that now we we are left with the very limited options here. And basically it comes down to, what would you do? Would you try to try anything and salvage this poor right ventricle, or would you just go straight ahead and list this patient for heart transplantation? Okay, yeah, well, there's not much else left here. And there are some people who are actually brave and would try to go ahead with some further management and not doing something that is completely irreversible. But I'll show you what we did. Oh, I lost my screen. Sorry, just gonna quickly share my screen again. And
it's there.
Oh, it's here? Oh, okay. Because to me, it shows something very interesting. Okay, because sorry, I just can't click. Okay, here. Okay. Anyway, so he was urgently admitted to the hospital from the clinic and started on combined management, intravenous combined management of his heart failure, which quickly improved his clinical symptoms, but only temporarily. But he failed transition from milrinone to oral after reduction and became milrinone dependent. And slowly his heart failure symptoms came back, and the decision was made to first to insert a ventricular assist device. Oh, sorry, I have to apologize. I'm not sure why is it not sharing. And it just shares the screen, but and he eventually was listed for heart transplantation and underwent the heart transplantation, and thankfully he's currently doing well and is just transitioned to into adult care. And as a summary, we have to say that this case demonstrated failure of all the usual management strategies, failure of the physiologic repair, as it resulted in a progressive TR and volume overload of the systemic right ventricle, and also failure of the LV retraining strategy. The LV didn't tolerate the bending as expected and failed to retrain, resulting in a progressive LV dysfunction. And he also failed the third strategy we tried, and we tried to relieve the LV pressure, but that resulted in a vicious circle, which with the progressive TR and the progressive LV dysfunction and stage heart failure. So we have to say that, yeah, so CCTGA is a complex lesion. We all know that with a very diverse and challenging management. And the RV systolic function is an important determinant in outcome, and it typically declines with age. But we also should not forget about the LV. And this shows very well that one strategy doesn't fit all. And actually, in this case, none of these strategies fit that patient, unfortunately. And timing of the interventions is critically important. Thank you very much. This is what I wanted to show. And I hope, I wish everyone a very nice summer.
Thanks so much, Audrey. That was a terrific case and very beautifully demonstrated. It's a pleasure now for me to introduce our next speaker, Luke Mertens, my colleague here in Toronto. He joined us here in 2008 to be the section head of the Echo Lab. And he's also the co-director of the Pulmonary Hypertension Program and a senior associate scientist for the Research Institute. He's a professor of pediatrics at the University of Toronto, and his clinical expertise is in pediatric echocardiography and vascular imaging. He does research in cardiovascular function in children with acquired and congenital heart disease, and on the development and validation of novel echocardiographic techniques. Luke's been involved in leadership positions within different professional organizations, both in Europe and North America. Over to you, Luke.
Thank you, Mike, for the kind introduction. So now I've been given the challenging task of talking about valve function in congenitally corrected transposition. I'll share my screen here. So to simplify things, because it's a quite complex topic. Yeah, it's quite a complex topic. I decided to focus on the tricuspid valve in congenitally corrected transposition, which obviously is the main valve you want to assess. But we have seen in previous presentations that you shouldn't forget about the mitral valve, which can be abnormal in this condition. And also, if you think about double switch procedure, you have to assess pulmonary valve function if you want to do a double switch where the pulmonary valve will become the future neo-aortic valve. So obviously, that's also important in your assessment. But I decided to go for the tricuspid valve and look a little bit more in depth into the tricuspid valve, because that's the main valve that is dysfunctional in this lesion. And there's a very high degree of variability in valve morphology, which will influence the future of your patients and will also influence your decision-making you're going to make. Before I go into the abnormal tricuspid valve in congenitally corrected transposition, I will review a bit, kind of remind you about normal tricuspid valve morphology, and especially kind of the variability that can exist in normal tricuspid valve morphology as we learn more about the tricuspid valve from three-dimensional echocardiography. I will zoom in on morphology in congenitally corrected transposition. We'll show you a few cases on tricuspid regurgitation in congenitally corrected transposition and the surgical implications. The tricuspid valve is a very interesting valve, and definitely in adult heart disease, a very understudied valve. It is the largest valve in the heart. It is typically the more apically positioned valve relative to the mitral valve. It has important structural components like the mitral valve that are to be taken into account, and I'll briefly review those in a normal valve as we look at the abnormal valves in congenitally corrected. So that first of all, the leaflets, the papillary muscles, the chordae, and the annular size that are important if you want to define mechanisms of tricuspid valve regurgitation. When you look at the tricuspid valve leaflets, normally there are 3, but even in a normal anatomy, that can vary between 2 to 4 leaflets of the tricuspid valve, and I'll show you some examples of that. So the anterior leaflet, the anterior superior leaflet, we should call it, is the largest and the longest leaflet of the tricuspid valve. The inferior posterior leaflet is the most variable one, can have multiple scallops, and sometimes can be not very well separated from the anterior leaflet, and that can result in this bicuspid appearance of the tricuspid valve. So the septal leaflet is the shortest valve typically in length, and is also the least mobile leaflet with septal attachments. And that's very important in the context of congenitally corrected transposition, as I will illustrate later. As I mentioned, kind of sometimes, and this is a pathologic example where you can have more than 3 leaflets in the tricuspid valve, and that's mainly related to those deep scallops in the posterior leaflet of the tricuspid valve. Here you see kind of this posterior leaflet is separated by a very deep scallop into an almost separate leaflet, as you can see in this image. If you look at the commissures, the largest commissure, because it's important to understand some mechanisms of tricuspid regurgitation, the longest commissure is the one between the anterior and the septal leaflet. So if you compare it to the other commissures between anterior, posterior, and septal leaflet, those commissural lines are much shorter. Important to know is also the commissural length. It's kind of like the height of the the commissures. It's normally between 5 to 10 millimeters, so which gives you kind of the coaptation reserve. As the annulus dilates, kind of this is the reserve you have in commissural length. As this stretches out, your length of the commissures will shorten. Papillary muscles are very distinct in the tricuspid valve and often forgotten, and they're very interesting. The largest papillary muscle of the tricuspid valve is the anterior one, which often is fused with the moderator band, as you can see in this particular pathologic example. The posterior leaflet, and when it's definitely more by leaflet type, has typically 2 or even 3 papillary muscles attached to it. And the least well-developed papillary muscle of the tricuspid valve is the septal one, as the septal leaflet has typical chordal attachment directly to the interventricular septum. So, and that explains somehow the decreased mobility of the valve. We can clearly and can nicely show that by 3-dimensional. I picked some 3-dimensional images from our archive, and you can clearly identify the septal leaflet, the large anterior leaflet, and the infero-posterior leaflet. The posterior leaflet is more positioned inferior rather than posterior. In this video clip, you can see that kind of, and this is something I borrowed from Roberto Lang in Chicago, where he had a lot of adult cases. And here you can see the variability in adult morphology when you look at it with 3D anatomy, that you can have a lot of variability in tricuspid valve morphology, with sometimes 2 leaflets, most of the time 3 leaflets, but as illustrated in this very rare case, it can go up to 5 leaflets. So what type of abnormalities do you have in congenitally corrected transposition? And if you look at pathologic series, and this is one from Bob Anderson group together with Norman Silverman, where they looked at pathological specimens of congenitally corrected transposition, they found tricuspid valve abnormalities in up to 90% of patients. Obviously, the most common, and that's very well known, the most common is kind of this Epstein type abnormality, Epstein-like abnormality with apical displacement of both the septal and inferior valve leaflets. The main difference, however, between Epstein malformation and tricuspid valve abnormalities in congenitally corrected transposition is that you have absence of thinning of the atrialized part of the right ventricle. So even if you have atrialization, you'll see that you have preservation of the RV myocardium. So you see that nicely, and this is an image I borrowed from Andrew Cook. So you can nicely see that in this particular example where you have this displacement, and so the absence of delamination of the posterior and septal leaflet in this particular example, but you see that you have preservation of the right ventricular myocardium, which makes this in congenitally corrected transposition very different from Epstein malformation. So where you have this thinning of the atrialized part. So what you also have, and this is from the same paper, is that you have the plane of the tricuspid valve is typically displaced and rotated. And this is often forgotten when we look at echocardiographic images. In all those cases that they identified that the anteroseptal leaflet is typically not displaced like you would see in Epstein malformation. The leaflet that is the most severely affected in congenitally corrected transposition is the infero-posterior leaflet that is the most apically displaced very often in the pathologic specimens and can even be absent in some of the examples they saw. Typically, the RV size is preserved. So now let's look at some cases. And this is a first example where at first sight, you can see kind of this, there's definitely a leaflet dysplasia here. And what you can see in this particular example is that you have a relatively good mobile, although somewhat dysplastic anterior leaflet, which you can also have in Epstein malformation. But you have somewhat tethering of the septal leaflet. With, as you notice here, severe tricuspid regurgitation. So the septal leaflet is definitely tethered in this particular example. don't forget to look at the inferior leaflet. As I already mentioned from pathologic examples, the inferior leaflet is often the one that is the more severely affected. And in this particular example, that's also the case. If you look more inferiorly, you see that there is more feathering of the inferior leaflet. The best view to obtain the inferior leaflet is to go to a long axis view and tilt inferior posterior in your long axis view. Here you see the typical example of a very feathered inferior leaflet that opens in the direction of the right ventricular outflow tract and is very abnormal. And you see the opening of the tricuspid valve is more severely displaced in this particular plane. And you have quite a lot of tricuspid regurgitation coming from the commissure between the anterior and the inferior leaflet. So you see the inferior leaflet to be significantly displaced in this particular example. So the mechanisms of regurgitation you have to carefully look at when you look at patients with congenitally transposition. And one is definitely leaflet abnormalities as illustrated, but you can have associated with that, and in some cases it's the predominant mechanism, annular dilatation, which can progress over time. Your annulus can progress related to the volume added by tricuspid regurgitation. Prolapse of the leaflets is more unusual on congenitally corrected transposition, and leaflet abnormalities definitely are more common. Progressive tricuspid regurgitation is linked to RV dysfunction, as alluded to in previous talks. It's a systemic RV doesn't tolerate additional volume loading. So you can get into this vicious circle where progressive tricuspid regurgitation results in more dilatation, results in more tricuspid regurgitation. This ventricular-ventricular interaction has been alluded to in previous cases, and this is the same images I've shared before. And this patient underwent PA banding, and this is acutely in the operating room, the TEE. During PA banding, you can see some degree of reduction in tricuspid valve regurgitation, but there's still kind of at least moderate residual tricuspid regurgitation at the end of the procedure. And this is related to the morphologic abnormality of the inferior leaflet as well in this particular patient. Something you shouldn't forget is that there are additional effects that can affect the degree of tricuspid regurgitation. And this is a recent baby we saw, 3 months old, with congenitally corrected transposition. As you can see, is quite severe tricuspid regurgitation. But in contrast to the previous example, you see that there's good delamination of the leaflet. And here you see the inferior and anterior leaflet, which is good mobile, but there's quite severe tricuspid regurgitation. But there's also large VSD with a large left to right shunting. And if you look here at this apical four-chamber view, you see a severely dilated left atrium, a dilated right ventricle. And here there was also quite significant annular dilatation that was related to the volume shunt caused by the VSD. You see that also the septal leaflet in this particular example is quite good mobile. And there's no obvious significant structural abnormality in this particular example. You see a close-up view of the inferior leaflet, also from the apical view, and again, a better view on the inferior leaflet in this three-chamber RV view, where you can see that there's good mobility of the inferior leaflet. This patient underwent PA banding, and as you can expect, if you decrease the VSD shunt by doing a PA banding, that you will have improvement in tricuspid valve regurgitation, which is not only kind of necessarily related to shifting of the septum in this particular case, because you could say that the LV was at systemic pressure in this particular example where you have a large VSD. So there was egalization of LV and RV pressure. The main effect in this particular example comes from removing the left to right shunting, where you see that significantly improved RV dilatation and significantly improved the degree of tricuspid regurgitation. So this is the PA band after one year. This is another recent example we saw of a newborn with congenitally corrected transposition with a very abnormal tricuspid valve. And this is kind of a more extreme form of tricuspid valve abnormality. And you see that already when you sweep through from apical view through this very severely dilated left atrium, very severely dilated right ventricle, this very mobile anterior leaflet and this very restricted motion and very abnormally septal leaflet of the tricuspid valve with severe tricuspid regurgitation. Again, don't forget the inferior leaflet. And I already alluded to the fact that you can see it very nicely in this tilted long axis view, where you see the inferior leaflet also being very abnormal in this particular case, with again opening of the tricuspid valve in the direction of the right ventricular outflow tract, in the direction of the aorta, which is better illustrated even in this image, where you have the severe Epstein malformation of the tricuspid valve with very dysplastic and abnormally delaminated tricuspid valve leaflet. So here again, you see that from the apical view with a very abnormal septal leaflet, good mobile anterior leaflet. And this patient underwent PA banding. You can already predict that the effect of PA banding in this particular case is not going to be very significant. And you see after PA banding, you still have severe tricuspid regurgitation, which is again related to the very abnormal inferior leaflet. You see that again from the apical views, that there is still quite severe tricuspid regurgitation, and with no significant improvement after PA banding. The gradient on the PA band was not very high. You may state that probably was a bit underbanded, but still I don't expect here to be that the effect of bending and shifting the septum over to the right ventricle is going to have a significant effect on tricuspid regurgitation. So that makes it a big problem for this particular patient, because what can you do next if you have this degree of severe and abnormal tricuspid regurgitant valve? Definitely, TR is one of the mechanisms that contributes to the development of right ventricular dysfunction over time. And it has been nicely shown that if, and those data have been presented, I won't repeat them too much already, that if TR negatively affects outcomes, that treating TR can normalize kind of the outcomes of patients. And that's having a degree of left ventricular outflow tract obstruction prevents the development of tricuspid regurgitation. If you have significant tricuspid regurgitation, and you're doomed to keep the right ventricle as your systemic ventricle. It has been shown, and that's been discussed also by Dr. Connolly in previous sessions, to replace the tricuspid valve. Nevertheless, when you think about how to treat the tricuspid valve in these patients, it's really important to go again and look carefully at the mechanism of the degree of tricuspid valve regurgitation. Because looking carefully at the 3 leaflets of the tricuspid valve, if you have 3 leaflets, can help you in understanding what effect you're going to have of PA banding. Because it's not true that you will have a significant effect in every patient, because in some patients the tricuspid valve is just too abnormal. So tricuspid valve abnormality, like in normal patients, that definitely in congenital corrective transposition is highly variable. The mechanism is often a combination of leaflet abnormalities, annular dilatation, and some degree of septal shifting related to the unfavorable LV-RV interactions. PA banding can stabilize the progression and reduce TR severity in anatomically favorable cases, I would say. Tricuspid valve repair is challenging because of the complexity of the tricuspid valve. And if you need something to be done to the valve, replacement is the preferred strategy. So thank you for your attention.
Thank you very much, Luke. That was an excellent talk, as always. And I have the distinguished pleasure now of introducing our next speaker, Andrea Dragulovsku, who I am honored to work with. Most days in the Echo Lab, it's the kids. So Andrea initially hails from Romania and completed her medical school there prior to going on, she did adult cardiology training there prior to going on to doing her pediatric cardiology training in France and in the UK. She joined the kids in 2009 as a fellow and as a staff cardiologist in 2013. And her clinical and research focus involves new methods to assess ventricular function and ventricular vascular interactions. So without further ado, Andrea and Luke, if you can stop sharing your screen.
Hi, Lindsay. Thank you very much for the introduction. I will share my screen. Please confirm that you can see my screen.
Not yet. Now we can.
Yep.
Yep, excellent. All right, good afternoon, everyone. I want to thank the organizers for the invitation to present in this meeting. It is an excellent program, and I'm honored to be part of it. All day today, you've already heard quite a lot of about this interesting and complex lesion, from embryology to morphology, natural history, and the different types of intervention that are used in this population. This session is focused on imaging, and my role is to talk to you about the echocardiographic assessment of ventricular function. And that's a pretty broad title, and there are a lot of things to take into consideration. Have no disclosures. To start with, I want to talk about why are we so interested in a ventricular function. You've seen from earlier presentations that the right ventricle in systemic position tends to dilate and fail, that the tricuspid valve is a common problem, often related and aggravated by ventricular dilatation and dysfunction. And often we run into rhythm trouble, which can also contribute to the ventricular dysfunction and development of heart failure. When we talk about ventricular function in congenital corrective transposition of the great arteries, we have to take into account a lot of different factors, as I said before. Are we before or after an intervention? Is this a pre-operative assessment for a specific planned procedure? What type of procedure? If post-intervention, what was done? Is this an intermediate step or to another surgery or a destination? We look at both ventricles, which is a systemic ventricle and which is a subpulmonary one. We have initially the right ventricle in a systemic position, which may stay the same in some types of repairs, or we can have the left ventricle in systemic position. So we usually have to look at both ventricles. If we start in the preoperative assessment, have we actually planned one, or is this just a regular follow-up to a near future intervention? The assessment may be slightly different depending on our plans for the particular patient. And there are several options depending on the associated lesions, the age of presentation. You've already heard a lot about the different options, pros and cons, and what we can do with different patients. From not intervening to pulmonary artery band, a physiologic repair with a systemic RV, an anatomic repair with a double switch, a 1.5 ventricle, a single ventricle palliation in some cases, or end up with a transplant. And there are several echo parameters that we can use to assess ventricular function in patients with CCTGA, and of course, not only CCTGA, but we're talking about that now. I'm not going into detail about how to do each of these parameters. In general, we have to look at both ventricles, and overall, I think longitudinal assessment, looking at parameters trends, are very useful and should be performed in a protocolized manner. I'd say to look more in detail as soon as a qualitative assessment goes below normal, and include TAPSE-MAPSE, tissue velocities, fraction area of change for the right ventricle, Simpson ejection fraction for LV, do 3D ejection fraction whenever available, and imaging is adequate, and longitudinal strain at least in the 4-chamber view. I won't touch into the desynchrony assessment, that there is another session tomorrow focused on that. And now I'd like to go through a couple of cases focusing on function and go through some literature before drawing my conclusions. The first case is a neonate, with a prenatal diagnosis of congenital corrective transposition of the great arteries and a large subpulmonary VSD, which you can see here in the left upper image. He also had an interrupted aortic arch. There was good ventricular function, no significant AV valve regurgitation. And because of these associated lesions, the patient underwent an arch reconstruction and a pulmonary artery banding at day 2 of life. This is the echo at 1 month post-band. You can see here the band in good position with a good gradient on the band. The pulmonary arteries are a good size. The ventricular function is good on both ventricles, and there is only mild tricuspid regurgitation, no significant mitral regurgitation. The arch was unobstructed. It was clinically well, growing and developing normally. Here at 1.5 years of age, with saturations that were slowly decreasing. The echo at this point showed a PFO that was shunting now right to left, maybe mild to moderate TR, with a high gradient on the PA band. The arch remained unobstructed. And looking at the ventricles, both you can appreciate from these images, both have good function. The septum is neutral. There is good thickness of the LV free wall, as well as good thickening of this left ventricle. There is normal left ventricular ejection fraction and normal right ventricular fraction area of change. You don't need a more detailed assessment in this particular patient to conclude that the left ventricle is suitable for a double switch procedure, which actually happened a couple of months later with a good result. And here is the echo a couple of months after the double switch procedure, where again, just focusing on the function, we have good ventricular function. We see now that the left ventricle is systemic. The septal curvature is bowing towards the subpulmonary RV. In 4-chamber view, good function. We have the pulmonary venous channel here coming towards the right-sided atrium. It's unobstructed. We have a mild to moderate TR, but no MR, and overall good function. There also was mild neo-AI that needs to be followed, as you've heard from previous talks, that can be an issue in the long term. So this one went very well, very nicely with no complications. Let's move to another case, another corrective transposition CCTGA, with this one with multiple VSDs and an epsteinoid tricuspid valve. It was followed in an outside center and was referred for management with heart failure and complete heart block. So at 2.5 months of age, the patient had a PA band and an epicardial pacemaker implantation. Patient was clinically well until more or less 3 years of age, when she presented with lethargy and was diagnosed with a lead fracture. Went to the OR and had a lead replacement and a generator change at that time. And this is the echo at discharge after the lead replacement, showing a good ventricular function, but the tricuspid valve that is quite leaky, moderate TR. We have persistent multiple muscular VSDs. And the PA band was well seated with a good gradient on it. So she continued to be followed at the outside center, and at the age of 5, she remained clinically well, but on echo, it was noticed to have mild left ventricular dysfunction. The RV function appears relatively preserved, but with worsening tricuspid regurgitation. There are still multiple VSDs. The VSDs didn't go away, with significant shunting bidirectional at the level of the VSDs. So in surgical conference, the decision was to continue to wait with close monitoring, hoping that some of the smaller VSDs might still close. And 9 months later, though, the patient presented in heart failure, now with a significantly dilated left ventricle, with moderate to severe left ventricular dysfunction. Now we have more mitral regurgitation at a moderate degree. The RV appears relatively preserved, maybe mildly reduced, but again, with in the setting of severe TR. So you always have to take into account the degree of tricuspid regurgitation when assessing ventricular function. The decision was to go for a cath with balloon dilatation of the PA band to relieve the pressure on this failing left ventricle, and also a BSD device closure. Unfortunately, the patient remained in severe heart failure, requiring inotropic escalation, and in the end, a bad support as bridge to transplant, which happened about 3 months after this. And the patient is now doing well almost 3 years after a heart transplant. So you see 2 patients with early bands, both of them, but very different trajectories otherwise. And I would say that possibly mainly related to this tricuspid valve that was very leaky in one of the patients. Now, a lot of the papers that I have prepared have already been shown in earlier presentations. I will still go through some, and because I want to emphasize a couple of points. This is a study from 20 years ago that looked at adult unoperated patients with congenital hereditary transposition of the great arteries, included 44 patients. 30 of these patients had surgical interventions, all tricuspid valve replacement. And in their analysis, the only predictor of post-operative heart transplant was pre-operative right ventricular ejection fraction. So the systemic ventricular ejection fraction was the only predictor for need for heart transplantation. Now, I will jump to a publication from this year. This is a nice paper that included 233 adult patients with CCTGA. The authors used echo-derived strain to describe their findings and correlate them to both functional and clinical outcomes. And they found that most of the patients had left atrium and right ventricular, so systemic chamber dysfunction with reduced strain. And as well as a couple of them had right atrial and left ventricular dysfunction, and with some elevated LV pressures. These systemic and non-systemic indices were associated with cardiovascular events, as you can see in this table, that were defined as heart failure, hospitalization, transplant, death, but also with a symptomatic status by NYHA class. In their risk prediction models for cardiovascular events, they found that the right ventricular fraction error of change and right ventricular strain had comparable prognostic performance, which is important since fraction error of change is likely more commonly used in daily practice. We try to use both, especially when we notice some degrees of dysfunction. They also found a very strong correlation between the left ventricular and right ventricular function, consistent with previous studies that found strong correlation between left and right ventricular strain. And I also want to emphasize another finding of this paper related to the changes in atrial size and function and the impact on the left heart. The systemic left atrium was enlarged in 76% of the patients, and 71, as you can see here, had reduced LA function as defined by left atrial reservoir function. The very high prevalence of reduced LA strain would suggest that progressive development of right ventricular diastolic dysfunction could be an important marker of disease progression. So monitoring the LA strain could be an important parameter in this population. And this was also discussed in the editorial published with the paper. Now, the Boston group, this paper was also reviewed earlier in several of the talks. They published recently on the management of CCTGA with intact ventricular septum, and they included 128 patients, 50 had a PA band, and 35 went on to have a double switch. The management varied depending on the age of presentation, with a PA band followed by switch if patient younger than 10, and progressive RV dysfunction or TR, and only palliative PA band if over 10. But again, this is the limit of 10. It's somewhat arbitrary, and you can have cases that can still go for a double switch later on if the ventricle post-band appears to be conditioning well. Here you have in this graph the freedom from composite endpoint, death, heart transplant, systemic ventricular dysfunction, and AV regurgitation. Looking forward further at the systemic ventricular dysfunction, the Mayo group looked at 186 patients showing an annual decline in the RV strain of about 4%. And this was associated with cardiovascular events irrespective of the baseline right ventricular function. The authors identify several risk factors of progressive decline in right ventricular function, including hypertension, left ventricular systolic dysfunction by strain, left ventricular pacing, and right atrial hypertension. As mentioned earlier, I took out a couple of slides of papers that had already been presented in previous talks, and I would just jump to my conclusion, where I would say that echocardiography is the first-line imaging modality in the CCTGA population, that the RV systolic function is an important determinant of outcome and typically declines with advancing age, that we need a comprehensive echo assessment in CCTGA that should incorporate quantitative measurements of right ventricle and left ventricular function, including strain measurements, and also consider adding the atrial strain as a marker of diastolic dysfunction. And I want to put an emphasis again on the serial assessment of functional parameters to detect trends that would facilitate an early intervention, as we know that once the ventricle is failing, there's not a lot of options that we have. And with that, I thank you for your attention.
Well, thank you very much, Andrea. That was a terrific presentation, and I'm sure we'll have questions which we'll save for the end of the session. It's now my great pleasure to introduce our last speaker, my mentor, Shi-Jun Yu, who joined us from Korea as a professor of medical imaging and pediatrics at the University of Toronto and the staff cardiac radiologist at Sick Kids. Jun leads the 3D printing program at the Hospital for Sick Kids, and his specialties include pediatric cardiovascular MR and CT, as well as fetal echocardiography. Jun has arranged the annual international hands-on surgical training courses and the monthly in-house surgical training courses for congenital heart surgeons since 2015 and 2019, respectively. He's published over 290 scientific papers and authored 5 books and 26 chapters. Welcome, Jun.
Okay, thank you, Mike. The organizers, would you mind that you're showing my face? The organizer says that you cannot start your video because the host has stopped it. Okay. So, anyway, can you hear me? And,
yes, we can.
Okay, so I can share my slide. Okay. Okay. Oops.
We see them.
You see my slide, okay? So I took this great opportunity to review that all MRI images we have in the last almost 20 years. So my fellow, the Ankabi Parasapram Wang and Achana Rai really helped me a lot in retrieving all the images and the information, and I really appreciate them. Okay, so actually what you're asking me to do is that talking about CT and MR and 3D modeling and printing. So I do not have anything to close. So CT and MR, thinking about is that the CT and MR together, we can show the anatomy very nicely. And with MR, talk about the blood flow, ventricular function, and tissue characteristics. If I think about today's topic given, I think you're asking me to talk about the anatomy shown with the so-called cross-sectional images. So why do we do all of this? I think the echocardiography, as the Andrea mentioned, is the really baseline good enough. But however, quite not infrequently, it gives a better understanding of morphology. And then secondly, surgical planning with a higher level of confidence. That is what I learned in talking to surgeons. So let's say the echocardiography and CT scan, and confidence level might not be very, very high. But however, as soon as I show 3D modeled the pictures in the rotating in various way, and then give them 3D printed models, I do find that their confidence level rises up. And then the other is that actually pre-operative surgical simulation. It is more for training, but however, what if even the established step didn't have any chance to do a certain procedure? Why not practicing the surgical the procedure on the models I can provide them with? So this is the videotape that David and the POM made a few days ago about the setting procedure for double switch. So, oops. Okay, so, okay, here we go. Okay, so just to take a look at how it is the second layer for the systemic scaffold in the silicone molded model using. And both POM and I, that as non-surgeon, find that it is really, really high, the high-end surgery, and really needs a good hands and then experience too. So now that the kind of model is available, and then it is worthwhile to practice that before doing the procedure on the patient. Okay. So let me review that unique features in CCTGA, which already have discussed. And the first thing I want to emphasize is that there is the frequent association of abnormal sinus and abnormal heart position, including sinus inversus in 10 to 20%. And dextrocardia and mesocardia in more than 25%. And then it's not just the heart position, but the unusual ventricular relationship, crisscross the connection or twisted AV connection. In 10%, in the transposition, complete transposition, you don't have your 10%, but in CCTGA, there is frequently ventricular relationship is abnormal. And systemic right ventricle, myocardial architecture is not good for systemic ventricle. Frequently, septum is bowing toward the left ventricle, which has significance, and then limited coronary arterial flow reserve of the right coronary artery for the systemic right ventricle. And tricuspid valve, we have already talked about incompetency, dysplasia, and abstain. I will talk about a little of this from different perspective. And then LVOT, in terms of compromise of the LVOT dimension and abnormal tissue, aneurysm is not infrequent in the left ventricle outflow tract. And then we already have talked about the abnormal AV conduction. Okay, so let's think about sinus inversus. I think it is an important thing to think about because that David wants to do the surgery on the right side of the patient if it is sinus solitus. However, if it is sinus inversus, you need to go to the other side. And then his right hand, the left hand, using in that situation, quite be a little bit tricky and different. More importantly, when you have a mesocardia and dextrocardia, which is more than 25%, and David Barron is claiming it is difficult to the access to RA and LV at surgery. And then if you want to do the sending operation or mustard operation, less atrial tissue is available for sending. Okay, let's take a look at what it means. So this is the reconstruction of exactly those cases. Okay, so if you look at the setting, what David we're going to do is the 3 layers to go, and then all the pulling and it's just this complicated surgery. And it's better to have a good space for the right atrial approach. Okay, so in the upper column is a frontal view. As you can see here, for the mesocardia, right atrium is really, really hiding. And then dextrocardia, you don't see it from front. Even if you take the lateral view, you can see in levocardia case, right atrial surface seen is quite wide. However, in mesocardia is much less. In dextrocardia is even the smaller. So if you compare that in the 4-chamber plane, in the levocardia, the available space for the David to do sending is this much. However, in mesocardia, it is much less, and in dextrocardia might be very, very little. And then available intraatrial septal tissue is also different in terms of the orientation and amount of septum to deal with. So this is another case really in 3D. It is important to see just the adding additional information to echocardiography. Here in this case, you can see that here, on the left side, 4 panel is that the right anterior oblique coronal plane. If you look at the ventricles, they are superior inferiorly related, and the mitral valve inferiorly located is opening in this direction. So, however, the tricuspid valve is higher up and then opening the superiorly. Already in the coronal view, axis is different. So if you look at the tricuspid valve superiorly located in axial view and mitral valve below, the axis is completely different. So then the anatomical understanding is very, very challenging. And then there is a time I find that here, this cross-sectional imaging in a series, same interval with the same distance, same orientation is very, very helpful. So you can see that here in this short axis view, the right ventricle is up and the left ventricle is down. You have mitral valve opening here, and tricuspid valve is not in phase and is partially in phase. And it appears to be double aortic right ventricle. However, if you look at it very carefully in the 3D reconstructed images and 3D printed model, and actually it is more likely a discordant VA connection than double aortic right ventricle. So I will show you that why I think so. So this is a classic crisscross heart or twisted heart in the presence of the congenitally corrected transposition. What happened is that in the left side diagram is classic the congenitally corrected transposition. If you hold that heart with your left hand back and then rotate the apex of the heart in counterclockwise, you're going to have your right ventricle up, left ventricle down, and then you're going to have this ventricle relationship. And then that is what you see in the crisscross heart, twisted heart in the presence of discordant AV connection. So this is a 3D printed model, and then you can see right atrium connects to the left ventricle here, inferiorly located, and then you have your left atrium connecting to superiorly located right ventricle here. Okay. If you make the septal view seen from above, is completely different story. So I will show you it separately here. So showing this model, my question to you is that does this patient has discordant VA connection or a double aortic right ventricle? In image, it looked like a double aortic right ventricle, but if you look at this 3D print model, you may think a little bit differently. So seeing the septal surface here, so this is tricuspid valve orifice, right ventricle, and aortic outflow tract. You have your VSD or something else. So question is it VSD or is it VSD? And this is the aortic the pulmonary outflow tract. Okay, so I pass the probe into that area from the left ventricle up into the pulmonary artery, and then I can show you this way. Okay, so that is really that VSD is directly directing that pathway to the pulmonary artery. And then seeing this, I'm thinking that this is a VSD, not the really what you usually see. Oh, this is a defect in the horizontal ventricular septum. So what I'm seeing here is that the understanding of surgical anatomy can be significantly different if you have your 3D printed model in your hands. Okay, so this is an example. Okay, let me move to the next topic, systemic right ventricle and tricuspid valve. Okay, so there are papers coming. They are doing diffusion tensor imaging to look at the 5 orientation and the some kind of thing. I don't have any idea that I can talk about this, but this is just coming, and then probably in 5 to 10 years that could have some clinical implication. But however, they are doing currently not yet. Okay, so that's why that I don't have any experience. I don't talk about that much. Okay, so let's look at this ventricular septum. On your left side is short axis of normal heart, and on the right side is short axis of the CCTGA, the right ventricle on the other side here. Okay, in normal, traditionally we describe right ventricular ejection is produced 20-30% by the free wall and 70-80% by the septum. As a matter of fact, I don't fully understand how they conclude in such a way. But however, if you look at the congenitally corrected transposition, septal position is completely different. In normal, the ventricular septum is bowing toward the right ventricle. In this particular case, the ventricular septum is bowing toward the left ventricle, away from the right ventricle. That has a significant impact. So here you have your 2 CCTGA cases, very, very similar, the anatomy. But however, on your left, the right side, ventricular septum is really swinging. If you look at this case in short axis, you can see that the ventricular septum is very dysynchronic. And then actually it is sometimes that is in some sense dyskinetic. Okay, and then look at the left ventricular ejection fraction. Here on your left side, similar pathology is 49%, while the left ventricle is 78%, while right ventricle is 35%. How could the left ventricle has the 78% of ejection fraction? And then I begin to pay attention to what does the septum contribute to ejection fraction? Okay, so here, if you look at this case, so the left ventricle free wall contracts reasonably well, but however, 70-80% is produced by abnormal septal motion in systole toward the left ventricle free wall. So here is my really advice to cardiology, steps here. What I mean is that when you look at the ventricular function in CCTGA, you need to look at the ventricular septum and free wall separately. So what I mean is that in this situation, there are 2 issues you need to think about. So having the septal bowing toward the left ventricle. RV and ejection fractions do not accurately represent the real systolic function of the ventricles. Secondly, tricuspid valve leaflets are not able to pose properly in systole, causing TR, even if your tricuspid valve leaflets are well developed, even if your annulus is not significantly dilated, because the septum here, down here, as Luke mentioned, away from the right ventricle, causing coda, holding the leaflets, not able to go back to the proper position right. So you have your 2 issues for the tricuspid valve function. One is the annulus, and the other is the actually septum itself. Okay. So in that regard, so we need to think about annular dilatation versus septal bowing. Okay, so you have the annulus dilated, and then you're going to have tricuspid regurgitation. But at the same time, if your septum is separately bowing more toward the left ventricle, and then there is additional cause of tricuspid regurgitation, which justifies pulmonary artery bending to restore the septal position back to the right ventricle. Okay, so the septophilic tricuspid valve with the caudal attachments to the septum is prone to leak when the septum bows toward the left ventricle. Okay. So moving on to that, the clinical case is here. In this case, it's not abstinence malformation, I would dare to say. Your posterior leaflet is well formed and large, but however it is leaking, and the ventricle is dilated, significantly contributed by annular dilatation and the septal bowing toward the left ventricle, causing this degree of severe regurgitation. So those things that annular dilatation, leaflet development, and the septal bowing, all of this separately assessed to make a proper surgical guide. Okay. So I think that is a very important why in this paper showing that systemic right ventricle, the 80 cases with the TGA, arterial switch operation, and 30 CCTGA, regardless of what it is, severe TR is the significant hazard, factor for the future outcome. Okay. So tricuspid valve abnormality in CCTGA, tricuspid valve in a systemic right ventricle is an issue. Valve dysplasia, not uncommon. Abstinence malformation can happen, but probably not as common as it is described in the literature. And stenosis and double orifice, and the straddling and overriding. On your left side is abstinence malformation in otherwise normal heart, and on your right side is abstinence malformation in CCTGA. So in the abstinence malformation here in otherwise normal heart, septal leaflet is terrible. However, in this case, although there is some abstinence malformation, septal leaflet is pretty reasonably maintained. Okay, so this is the pathologic description. In abstinence malformation in CCTGA, atrialized usually not large, little or no thinning of atrialized right ventricle, and severe deficiency of septal leaflet is not very common. Anterior leaflet is not saline in most cases, and interestingly, it is more often in cases with VSD. And even more interesting in the literature is saying in situs inversus, abstinence is not common at all. Okay, so the last one that I want to emphasize is this. So we all know in CCTGA, membranous septum is larger than normal. What does it mean? So here in these two cases, you may say that the tricuspid valve is significantly apically displaced, but however, the separation here is all membranous septum. And in both cases, posterior leaflet is okay. So my advice is that we cannot describe this is an abstinence malformation simply by measuring the offset attachment between the tricuspid and mitral valve. Okay. Because that the offset attachment, exaggerated offset attachment, is due to large membranous septum rather than real abstinence malformation. Okay. So because that I used already 20 minutes all, I want to go to the last slide. Okay. Okay. So this one that I want to show. So this is the fraternal twin, having one is cytosolitus livocardia, the other is situs inversus and livocardia. Interestingly, both patients has the abstinence malformation without VSD or abstinence malformation. Interestingly, these two patients, when he did the CT scan, find that there is a finding of bronchiectasis. So both patients turned out to be primary ciliary dyskinesia. Dr. Ma and Friedberg actually reported in the circulation CV imaging of these cases. And then, interestingly, there are a couple of cases reported in the literature saying that CCTGA is associated with the primary ciliary dyskinesia. So having discussed that early in the morning today in the embryology and morphology session, that what is the cytosine burgess, what is the heterotaxy, what is the L-looping, and then those, to an extent, related to abnormal ciliary motion during embryogenesis. So I think it is worthwhile to pay more attention to that in the future assessment in all patients with the CCTGA. Thank you very much for your attention.
Well, thank you very much to all our speakers. We've got a few minutes for questions now before we round up. Let's see if there are any questions in the Q&A. I'd like to start off perhaps with one question for you, June. I was fascinated by your talk, but I was kind of expecting you to talk a little bit more about shunts and AV valve regurgitation, quantification, the assessment of ventricular mass and things like that. I mean, we've heard a lot about how difficult it is to predict how these ventricles are going to respond to changes in loading conditions and so on. And I wondered if you have any thoughts about whether MRI has a role in that.
I think the MRI has a role. The reason being that there is no blind spot. You can talk about every corner of your free wall and ventricular septum. As I mentioned that while I was talking, the reviewing 35 cases, all cine images, I find that ventricular function is completely different from what you see in otherwise normal heart. And especially septum has a significant difference between from the normal in the majority of cases. And having said that, it is worthwhile to look at the ventricular septum standpoint of left ventricular free wall, right ventricular free wall, and the septum completely different. And it might be worthy to report in such a way. And one more thing that Pam and I, actually Achana and I were paying attention to was that, let's say, septal position in systole and diastole, if it is significantly different, that should be looked at very carefully what it means. I will be able to have some answers if I carefully review one more time. And then it's just what I said while reviewing 35 cases.
Thank you. I see there are some interesting questions in the chat for some of the echo stuff, but just before perhaps Lindsay takes over for those, I might just ask you about the question that came up earlier on about trabeculations and how we segment the ventricles to measure ventricular volumes and so on. It seemed that there was a bit of concern about how accurate our assessments would be because of that. Is there any solution for that problem?
I do not think so. Although that I heard that in the early beginning today, so they don't like the radiologists not including trabeculations in the ventricle. You know, that is the really almost 30-year the problem we're having. No solution yet. I think eventually what is going to happen is that in 5 to 10 years, if the ventricle in cine imaging has completely homogeneous signal with contrast medium, and then we have a very nice 3D imaging of that, and then the software will automatically exclude trabeculations, and then we're going to have right volumes. But otherwise, with the current technology, I don't think it is possible.
Thank you.
Thank you very much, June. I think your questions about the septal alignment and the cines that you illustrated by MRI are really fascinating, and they lead right into actually, there's a couple of echo questions that I'll direct to Andrea that have to do with that. And one of the questions, Andrea, is how has 3D ejection fractions of the systemic right ventricle, how have they been used? What are the cutoffs? Are they the same cutoffs, or should they perhaps be different?
Yeah, I think if we can do 3D ejection fraction, is great, and the more we do it, the better we'll get at it. I wouldn't get stuck on a cutoff value. I mean, yes, the normal ejection fraction, you would want it to be 45 and higher, but often in these patients, we have quite significant TR, which will increase your ejection fraction, but not in an output, systemic output kind of way. So you have always to keep in mind and be careful how you interpret a number as an ejection fraction without taking into consideration everything else, especially the degree of tricuspid regurgitation. So I think a trend, as I mentioned earlier, it's very important to look at each patient and measure longitudinally different parameters. That will give you more information and would be more informative of the evolution and prognosis of that patient regarding ventricular dysfunction, regarding degree of TR, and everything that goes with that, rather than a specific number.
Yeah, it seems like that's been a recurring theme in many of the talks today, is that there's been a lot of encouragement of looking at an individual patient over time and following their trajectory rather than putting too much into any one quantitative parameter, because they're just very hard to assess, and it's a very complex disease. One of the other questions, Andrea, an evaluation of the right ventricle has to do with your experience or anybody's experience in using left atrial strain as a marker for RV diastolic dysfunction in this population, following that recent paper.
Yeah, I think the paper that I cited, it's very recent, and I think the numbers that came out are very interesting, but I don't think it has been used yet in clinical practice. But it's definitely something I think we should take into consideration. I think the classic diastolic parameters for a systemic ventricle are difficultly applicable in this population. As we know, we have a lot of trouble with the standard diastolic parameters in any pediatric or congenital heart disease. So in this complex lesion, I would say even more, but definitely something to look into and see what if there is a prognostic, it's confirmed as a prognostic value, or what would that look like? And again, I think it would be longitudinal trending of those numbers rather than a particular cutoff value. And again, this would be influenced by the degree of tricuspid regurgitation, by the dilatation of that atrium, but looking at the reservoir function and the conduit function of the atrium would be interesting to in the follow-up of these patients.
Those are excellent points. Also, in addition to that paper being very recent, it was also done in an adult population.
Yes.
And so we have a lot of difficulties with evaluating atrial reservoir function and strain in children in general with normal segmental anatomy. And Luke, actually, you wrote the editorial for that particular paper. So do you have any other comments or thoughts on looking at atrial function?
Yeah, it's a good point. And I think one of the things you have to take into consideration in the Mayo Clinic paper is that I didn't have a lot of patients with significant tricuspid regurgitation. So they were all either operated for that, or they were not included in the series for some reason. So that's a limitation, because we don't know what the effect is of significant tricuspid regurg on atrial strain. So they kind of that's one of the limitations in that manuscript. But as alluded to before, I think it's going to be a combination of parameters that's going to help us, and probably atrial strain is going to be one of the main parameters used for detection of early detection of diastolic dysfunction in pediatric cardiology. I think it has a lot of promise, but it requires some further study though.
And Luke, I have another very practical question for you that many people may be wondering about, or at least I wonder about sometimes. You gave a beautiful talk on the tricuspid valve, and as we know, even in normal patients, there's a tremendous range of morphology. But when I review these echoes, I often find that the posterior leaflet is not well imaged, actually. And so just from sort of a practical standpoint, can you just discuss, what are really the best ways to image the tricuspid valve by echo when you're dealing with children and as they become adults? When do you think about moving from transthoracic to transesophageal? And at what point do you feel like 3D imaging of the valve really gets you better information?
Definitely 3D imaging is always the best if you can get the images, which is sometimes a problem in Epstein. If you have significant Epstein malformation, it may be difficult to get the leaflets in one view, even by 3D. So you will still kind of have to rely on some of the 3D the 2D images to help to guide you. I try to illustrate specifically for congenitally corrected transposition, not to forget to look at the inferior or inferior posterior leaflet, because, and I stressed it in my talk, it's very often abnormal. And if you look at a pathological series, it is the leaflet that is the most commonly abnormal in this condition. And it's often forgotten because it's not in your apical views if you don't look for it, if you don't look posteriorly enough. And the best view to look at it, and I try to illustrate in my talk, is actually in a long axis view and tilt inferior, so that you tilt away from your septal and anterior leaflet, but you tilt a bit more inferiorly, and then you will see the inferior leaflet coming to the image. I think the short axis view can, and especially the 3D views, can be helpful from that perspective as well. I find kind of in congenitally corrected transposition, the long axis view the most helpful to look at the inferior leaflet. Andrea, any comments on that?
Yeah, I agree with what you're saying. And I think also the apical views, the rotated apical views, equivalent of two-chamber view of the RV from apical, can also be quite helpful to image that leaflet and the problems related there. But if you are able to get a short axis on trans view and with 3D, I think that the best way to look at it, and in children, we should be able to try the parasternal or subcostal. We can still get those images, and never forget to image it properly and identify where the problem is.
Yeah, I showed some images of the rotated apical views as well, especially if you go to a 2-3 chamber view, you can see it quite nicely, especially in smaller kids. In bigger kids, sometimes it's a bit more challenging to get the 2-chamber, 3-chamber views of the RVs.
Yeah.
You mentioned about the posterior leaflet based on the Norman Silverman's paper. But however, when I reviewed the 35 cases in MRI where posterior leaflet is clearly visualized in 2-chamber view, actually posterior leaflet surprisingly very uncommonly displaced and then reasonably well developed. And then that actually in the morning that Dr. Barron, they mentioned a little bit. So there is some discrepancy in what is in the literature, and then at least that the 35 cases I reviewed. So about the posterior.
But I have no good explanation for that, Sijon. I easily identified abnormalities in the echo cases I reviewed. And I showed you some nice cases of definitely abnormal inferior leaflet mobility and attachments in the cases I illustrated to you. And it may be worthwhile to go to a more systematic review of all the cases we have, both by echo and MRI, to answer that question. But maybe David can comment on that as well.
Yes, I was going to ask also for all of you about the use of both echo and MRI in assessing suitability after LV training for double switch. And there's a lot of discussion today in perhaps the role of pressure volume loops being a slightly more smarter way of re-understanding ventricular contractility and function. But do you think there are things on MRI and echo that we can use to try and give us a bit more information to reassure us the LV really is going to be suitable to go? And I particularly think about the setting where you're banded and what the diastolic behavior of the ventricle is against a band, which isn't really quite the same as it's going to be against a true systemic resistance.
Yeah, it's always going to be, and for they've focused a lot of LV mass in the past, but I think LV mass, and definitely if you don't have an increase in LV mass and sufficient LV mass, then it's likely going to fail. But you will have also to look at kind of what type of hypertrophy you have, and there you nailed the point, David. And I don't know whether Sijon has the answer, whether in those cases we can distinguish physiologic hypertrophy from pathologic hypertrophy, maybe by T1 mapping or any of the novel MRI techniques where you can look for diffuse fibrosis. Because when you will have fibrosis in those cases, I hypothesize it's going to be more diffuse fibrosis rather than kind of the patchy fibrosis you can detect by LGE. And I don't know, Sijon or Mike, whether you have any comments on that, whether you would be able to distinguish between pathologic and physiologic hypertrophy in those cases, which you're right, David, that can result in significant diastolic dysfunction.
What do you think, Mike?
I think it's something we should look at. I was also interested about this question about perfusion that Ram and Mani brought up, whether you could do some sort of perfusion assessment to think about the microvasculature. But anyhow, it's a tough one. And maybe, you know, I mean, maybe...
I would say that here, that tissue characteristic, the problem of your current technology is that there is a huge overlapping between normal and abnormal. So which means that we'll be able to get the result. But however, issue is that we'll need 500 cases or even more to really get the conclusion, because to overcome this kind of significant overlapping of this, and then otherwise that it is very difficult to get the proper conclusion out of that study, in my opinion.
Maybe
Lars might not be really agreeing with me, but however, that is a criticism about the tissue characterization.
Although it may be useful to trend within a patient, which is what we've been discussing for many patients, regardless of the imaging modality and their age of presentation. So if you were to band them and you were to see that there was a progressive, more responsive hypertrophy, that could perhaps be something. But I think everyone has been saying the same thing, which is we really need to understand better what's happening at a histologic level and then physiologically as well. I think I'm going to wrap up the day for us. It's been a tremendous day of exploring CCTGA. I want to thank all of our speakers and panelists for their outstanding presentations. We were fortunate to hear from people all over the world. And what I think was remarkable is that even though we saw some of the same papers presented in different sessions, everybody had a slightly different spin on it or interpretation, which really led to lively and engaged discussion. So thanks to the audience members who participated as well. As a reminder, everything is being recorded and can be watched live again on the CHA YouTube channel. And then in addition, in order to get CME credits for your day-to-day, you'll have to respond and give us feedback through a link that will be sent by Sue Morton after the conference. So thank you again for everything today. We will resume tomorrow, Friday, at 9 o'clock Eastern time. Have a good night, everyone.